mobilization of urethra plate and urethra. You may use one step from all these steps. You may use all the steps in one patient. Nobody knows, nobody can expect what is the preferred or the perfect method for repair of penile rotation until now. Maybe penile torsion repair using dorsal dartus flap rotation. Many paper about the efficacy of this maneuver, just declaving, harvesting the dorsal dartus flap like the second layer in hypospadias, and rotate this dorsal flap on the other side of rotation. If to the left side, rotate it from the right side. If to the right side, rotate it from the left side, just and fix it to tunica to the torsion of the penis. Their conclusion, the dorsal dartus flap rotation is an excellent option for repair of penile torsion. It results in successful repair of the torsion, has few complications, and can easily be performed concurrently in the setting of other penile surgery. Many papers documented this conclusion. Another one, penile torsion repair by suturing tunica albuginea to the pubic periosteum. One of most important steps may be in resistant cases after skin realignment, after degloving, after the dorsal dartus flap, still torsion present. You may use this maneuver by suturing after degloving of the penis and dissect the periosteum of pubic bone. You may use to fix the penis to the pubic bone to the torsion of the penis. The technique of degloving the penis and reattaching the skin can't reliably correct penile torsion in their experience. Lateral suturing of tunica albuginea to the pubic periosteum to repair penile torsion appear to be better technique from their experience. Like this photos. Another one, prefer spiral Nisbet plication, which is a simple maneuver by spiral incision of tunica and plicate it in oblique maneuver may make the torsion of the penis. They concluded that is a simple and effective method for simultaneous correction of penile chordee and torsion, but long-term follow-up is necessary. Another one, penile torsion corrected by diagonal corporal plication, one at proximal, one and tunica and one the other around the neurovascular bundle, and they concluded that if the erection demonstrates persistent penile torsion, this diagonal corporal plication suture is much easier to perform than suturing the corpora to the periosteum of the pubis, which need more and more dissection. There is an old idea, 1976, complete dissection of urethra from corpora may be the only way to correct this penile torsion, which about 180 degrees. This 1976. Until come again 2014 by Bhatt from India, correction of penile torsion and chordee by mobilization of urethra with spongiosum is in chordee without hypospadias. He started from the start by this technique. Complete dissection of the urethra from corpora, complete granuloplasty is the major dissection, major operation, major techniques for maybe torsion need only simple repair or skin realignment only, but this is his concept. He started by penile degloving, if okay, if not mobilization of corpus spongiosum and urethra, still presents mobilization of urethra into glands, or proximal urethra mobilization up to pulpal urethra, or single stitch dorsal plication. Step by step, it provides excellent cosmesis, is safe, reproducible, and efficacious from his side of view. But I think it's very dangerous to make complete dissection of the urethra from the corpora just for torsion of penis for baby. This is another technique for, at the end of the day, penile torsion repair in children following ladder step technique. Simpler steps are usually sufficient. He started by complete degloving. If less than 30%, it's okay. If more, I may need skin realignment. If corrected, okay. If not, dartus flap rotation. If it's corrected, complete resolution, okay. If not, corpopexy. Not started by corpopexy, not started by complete mobilization of urethra, just start step by step until correction, which is maybe accepted for you. If less than 30%, it's okay. Not the perfect position, not zero position, no one looking for these results. Most of techniques used in penile degloving and skin reattachment is about 50%, dartus flap is about 24%, corpopexy 16%, degloving only 12%. Take home message. There is no consensus on the best repair for this condition. No constant relation can be made between the degree of torsion and specific techniques. No one knows if it's severe, I will need some techniques. If not, I will need another one. No one guarantee about the technique of repair. Simpler steps are preferred for correcting the torsion as they avoid the morbidity and complication of more complex procedure. A step-ladder approach starting with simpler techniques until complete correction is achieved is a good option. There is no need to plan complex procedure in advance. However, a larger number of patients is required to strengthen this conclusion. Long-term follow-up of all techniques need to be evaluated. Thank you.
Thanks, Dr. Ihab. This is a nice lecture. Some surgeons, Dr. Ihab, prefer to wait for correction of penile torsion after puberty, especially if they are circumcised. Do you agree or not? And what's your opinion about this?
This is only the most recent point of debate about this issue of anyone need to correct something related to genitalia. Nowadays, they're forbidden in Europe before reach to puberty age. This is a matter of debate even nowadays for hypospadias, you know. However, in I hate the words of my experience, like something like this. But we are still in Egypt. You make or deal with penile torsion from 6 months to 18 months, like hypospadias, usually come in repair for or coming for circumcision. If you notice the major rotation or severe rotation, you may delay the circumcision until 6 or 8 months or 1 year. Circumcision and skin realignment alone may repair the penile torsion. So in Egypt, we're still working on this congenital anomaly from 6 to 18 months. You agree?
Thanks, Dr. Ihab. I have a question. If we corrected pre-pubertal, so at which degree you can advise your patient to correct?
We depend on 45 degree.
From
30 to 45 degree.
So any patient have a penile torsion less than 30 degrees, you can assure it and don't touch his patient.
Yes.
Yes, this is one of, I think it's one of good home message to audience that if you have a patient to have 30 degrees or less, you can assure it, don't correct it, don't touch it.
Yes.
Thanks, Dr. Ihab.
Any
questions from the
very
floor?
Very nice and excellent presentation. I have 2 questions. The first, you have said that fixation is one of the methods to correct the penile rotation. Fixation by fixing the tunica albuginea to the pubic periosteum. Yes. What is the anatomical site, the definite anatomical site?
Usually in all these cases, you depend usually on gets or test every time. You sure that this point, when fixed to periosteum of pubic bone, may correct the torsion and may get tested by artificial erection, stir rotation. You may use another one, proximal or distal. You can't predict which point and, until you dissect all the penis and try many times until to reach the about 30 degree of correction.
And what about the neurovascular bundle? What about the neurovascular bundle, which may be taken in the fixation sutures?
No, you are lateral to neurovascular bundle mainly. In all type of repair, you are lateral to the corpora, which is rotated, something like this. You choose a lateral side, it's away from neurovascular bundle.
And
you predict the anatomical side of neurovascular bundle in the dorsal penis, and you go laterally away from the urethra and away from the neurovascular bundle.
Yes. The other question is, what's the role of corporotomy in correcting of penile rotation?
Corporotomy alone or corporotomy excision and like Nisbet plication. Yeah, corporotomy alone will not repair the rotation, maybe repair the curvature. If you vary corporotomy or major corporotomy in the ventral part of the penis, may repair the curvature, not the rotation. However, the rotation usually need plication or excision of corpora and suturing to make shortening to this one and detorsion of the penis.
We can use one-side corporotomy for management of penile tilting. Penile tilting means rotation, tilting of the patient to one side. So we have to do corporotomy to lengthen the other side, or to do like Nisbet to shorten the other side.
There is a technique of diagonal. Just now there is a technique for diagonal excision or corporotomy in the lateral part of the penis, and this is one of techniques for repair of penile torsion. That corporotomy and also corporotomy and resuturing to make shortening of this one, which is takes penis to other side of the corpora.
Thank you.
Very much. Thanks, Dr. Ihab.
Dr. Ihab, thank you for this excellent lecture. Your message is to follow a stepwise approach. Regarding the penile degloving, how far you say I'm finished with degloving? هل لازم توصل للبينوبيوبيك جانكشن وتنزل السسبنسوري ليجامنت، ولا بتقول أنا خلاص I finished the degloving؟ لأن this is the most important step that can solve 90% of cases. What's your message in this step?
If you consider penile degloving is one of steps of operation and maybe the only the first and the last one, you should make complete degloving to the base of the penis to exhaust yourself for dissection, and you may need later on to fix the penis and symphysis pubis also. So degloving to the base of the penis is one of most important steps in this operation.
Yes.
Thanks, Dr. Ihab.
شكرا.
Thanks, Dr. Ihab. The next presenter, Professor Muhammad Omar, Head of Egyptian Pediatric Association. He will present early human papilloma virus vaccination in children, why boys matter.
Bismillah. Good afternoon, everyone. دكتور غطاس، مبروك المؤتمر. دكتور أحمد، دكتور عبد المنعم، ودكتور عمرو محسن. It's a great pleasure being with you here, dear chairpersons. It's an honor. Distinguished guests, international speakers. Actually, it was the first time for me to come for an andrology conference. I'm a pediatrician. I'm a pediatric intensivist. And it looks very weird because what's common is the medical companies out there, but they provide different medicine. So when everyone is asking me, Dr. Muhammad, why are you coming here? It looks very weird for me because they thought like I'm a pediatrician. Do I come like a patient? But now I knew if there is an issue, if there is an emergency, we have DZAC. Please don't misunderstood me. I mean, if one of my friends or someone else needs help, I would ask for DZAC. Bismillah ar-Rahman ar-Rahim. My lecture today will be concerned about the boys mainly and the vaccination. Especially, we as a pediatrician are concerned with the vaccination in children age. This lecture is not sponsored, so all the medical content is mine, and I'm free to speak about any kind of vaccines of anyone. The agenda today will be talking about the guidelines for the vaccine and why timing matters children, and why choosing the boys? I mean, we usually speak about HPV for cervical cancers, and no one speaks about boys. Should we vaccinate boys or not? And how to address and to talk with the parents and convince them with the idea. And what about the vaccine hesitancy in Egypt? So what's the recommendation for HPV vaccination in children? Actually, the recommendation in the American Academy of Pediatrics starts from the age of 9 years to 12 years that you can start giving the vaccine. يبقى احنا هندي الولاد من سن 9 سنين ل 12 سنة، دي مفروض بداية when we start to give the vaccine. في ميزة في الوقت ده it's more flexible ان انت تبقى في عيادة دكتور الأطفال when you come for your pediatrician and he is telling you we have a vaccine, you are oriented with the vaccination issue. انت رايح تطعم actually, so it's not weird for you انك انت رايح تاخد vaccine عند الدكتور. So the immune response at the younger age is much better, it responds more better وهتدي results أحسن، وده هنشوفه في البيبرز اللي جاية بعد كده. عندنا مشكلة دايما is it a sex related vaccine or not? So when you start giving the vaccine at a younger age and you convince the parents with the benefit of the decreasing the load and the burden of the disease، انت مش بتروح بيهم في حتة تانية اللي يقعد يقول لك لا و multiple partners و multiple partners. So it will be good to start early. الأمريكان Academy of Pediatrics احنا we missed one اللي فاتت. بعدين this is the أول واحدة كانت الأمريكان Academy of Pediatrics and the American Academy of the American Cancer Association Society. It gives the same recommendation for prevention of the disease, and it gives the same recommendation same as the American Academy. So what are the doses? If the child comes very initially in the beginning from 9 to 12 years of age, we usually give only 2 doses. First dose, 0 dose. Second dose, 6 to 12 months from the first dose. طيب لو جالنا بعد كده after the 15th birthday يعني هو 14 هيبقى في الزون الأولانية 15 or after هياخد 3 doses 0 1 6 زي فكرة الهيباتيتس same as like hepatitis B 0 1 6 هياخد 3 جرعات. طيب مين الانديفيدوالز وهياخدوا توقيت امتى؟ ادي الزونز اللي ما فيهاش خالص وهم صغيرين till reaching the age of 9 years we can start the vaccination from this age to give the protection. If we Google it هنلاقي ان WHO كاتبه حاجه شويه مختلفه a little bit different. كاتبين ان هم ممكن يدوا كله 1 or 2 doses مش 2. Why? When the WHO talks to the world, they speak about the cost benefit. So having one single dose instead of having no doses دوت هيبقى with a better protection. عشان كده WHO حطها بالطريقه دي. انما CDC اي European community they talk for the 2 doses and the 3 doses same as like. Timing does it matter? ايوه هيفرق قوي. The completion of the vaccine early in the age of 9 years to 12 years. If we started early, it will give a better protection rather than giving it later in life. This study is a very nice one. This one talks about what if the physicians start to speak about the vaccine by year 2042, if 10% starting 2030 started to talk with the parents about the importance of the vaccine, reaching year 2042 will be almost, we need a zero convenient من parents, they will come convenient by themselves. طيب, a recommendation from the pediatricians or from the physicians to give the vaccine. When, if we can see from the percentage here that almost 65% of the physicians, I mean in this area will be the pediatrician, are convinced with the vaccine at this age, بدري, عند سن 9 سنين. But most of them are convinced في الحتة بتاعت from 11 to 18 months of age. الكلام ده هيفرق معانا في ايه؟ ان احنا الهاي acceptance of the parents at this age, reduction وكونسيرن للفكره السكشواليتي اللي كنا بنقول عليها دي هتبقى مهمه. والفيزيتس اللي هو the child is coming actually for a regular visit for his pediatrician, this will help a lot to give the vaccine. الهيومن بابيلوما فيروس لما نيجي نتكلم عليه في systematic review هنلاقي ان let's make it a little bit wider so we can see it all. The dots down there, actually these are the baseline for the natural immunity that we have. احنا عندنا كده الخط ده اللي هو بالاكسبوجر بتاعنا. طب what if we give the vaccines? The green one, it's when we start the vaccine early. It gives us a higher titer of level of antibodies. And this one, if we start a little bit late, اللي هو اللي تحت الجرين, the one immediately down the green, اللي هم 2 doses, but we started at the age of 10 to 14. So if we started early, we give a higher titer and we give a better protection. طيب اللي جايين نتكلم عليه النهارده what's our topic is boys. Should we vaccinate boys ولا لا؟ وهنا بنتكلم على gender neutral vaccination. يعني هنا النهارده بنتكلم على men rights. There's always women rights. احنا المره دي لا بنقول boys right. Males are also affected by HPV same as بيتعرضوا ليه زيهم same as like females. Males of higher risk of developing oropharyngeal cancer وhead and neck cancers من HPV. Cancer affecting do not have routine screening. ما عندناش باب سمير. ما عندناش باب سمير. الwomen they have a privilege عشان السيرفيكال كانسر ان هم يعملوا باب سمير. احنا ما عندناش ده وبالتالي ده بيبقى usually missed وبالتالي ده بيدي اهميه للبروتكشن فور بويز. من البرسنتجز that we can see here ان الاوروفارينجال كانسرز والبردن بتاع الاوروفارينجال كانسر واللارyngeal cancers in males are much more higher than in females. Naturally there is a proper shedding of the virus عند الفيميل أكتر من الميل, more much than the male, and this is why the virus stays in the human body of males much more. طيب, are the countries and the national immunization program in many countries aware of this? Yes. They started all vaccinating just girls. Nowadays, if you can see all what's with the red, so they are vaccinating both males and females. But what about the area? We can see here, and adding Morocco, and this one recently too, they vaccinate males and females too. So, احنا مش جايين نخترع العجلة. Everyone knows this is not new. I'm not going to convince someone now. It's everywhere. But what about the cervical cancer in Egypt? We can see that the routine pap smear and routine screening actually is very low. I mean, this is most of the time, the years ago, and it's 2%. Now it's 1% in the last 3 years with the proper social media and people are talking about the disease and the HPV. Despite of that, despite of this, the screening is almost like 1%. So what about the burden of other cancers rather than the HPV doing cervical cancer? The anal cancer, oropharyngeal cavity, and laryngeal cancers, it's much more higher in male. Do we see this? Yes. As a pediatrician, sorry to tell you, the dermatologist and us, we see a lot of child abuse. And we see a lot of skin tags and genital tags, warts, sorry. So it's not a priority. People are not thinking that boys should be vaccinated. This is not a priority. No, it is a priority. And it's missed because of lack of the routine screening program that should be done. Males are less aware that they should be protected themselves. فلما تيجي تكلمه تقول له أنا هطعم ابنك سرطان عنق الرحم, this is not true. أنت بتطعمه, you are vaccinating him not against cancer, you are vaccinating him against the HPV virus. زي ما بتقول له أنا am vaccinating him against hepatitis A or against Haemophilus, influenza, diphtheria, tetanus. So I'm vaccinating him against HPV virus, not cervical cancer. If there is a benefit, yes, there is a benefit. We can see here, if we just vaccinated the girls only, and 40% of them, and compared to if we vaccinated girls and boys, we're vaccinating 40% of boys, this will give a better impact على مين؟ both الميلز والفيميلز. يبقى انا لما اطعم الفيميلز لوحدها ده هيدي ميزه بس لما اطعم الفيميلز and vaccinating the males too, this will protect much more females too, and this will be a better benefit for the community. طيب احنا النهارده بنتكلم على lack of disease awareness. احنا لازم يبقى في awareness starts from the physicians. We should be aware about the disease, the culture and religion. Is it of a value? في دكتور اطفال زميلنا مره كتب بوست من 3 سنين ان HPV is a very important thing and it's very important to be prevented for children على الفيسبوك على اللي اتعمل فيه. This is a vaccine for the multiple sex partners. This is a vaccine not in our countries, in our religion. This is so when people think this way, this is catastrophe. When the physician think this way, so we have to start with the physician. We have to convince the physician that this is not only a sexually transmitted disease. النهارده كل الستات اللي بتروح تعمل ليزر والبروبس بتاعت الليزر they can't transmit the disease. There is other way than the sexual only transmitted disease. الفير والمايث بتاع الفاكسينز, it's like at the time at the COVID, you don't get the vaccine, the COVID vaccine, they put a chip on you, they can trace you ever. They are actually tracing us with all the mobiles that we have. So the conspiracy thinking is not good in the vaccination and the protection. So we should address the parents, the individuals, the community, and the healthcare provider for the proper protection. Who is in charge? We should communicate with them. Ministries, universities, they have to be vaccine literacy, having the knowledge, the skills, the information to take a decision what to do. طيب, what's behind the vaccine and what's the benefits, the risks, safety, كل دوت لازم يبقى محطوط قدامهم so they can take a decision. زي ما Morocco, Kuwait والبحرين وتونس, they took a decision. We would be happy having this decision in our country too, because of the number of deaths per year is very high, and الجهل والignorance is the آفة الزمن. This is what's very destroying any country or any national immunization program بالنسبة لنا as a pediatrician. Thank you very much.
Thank you, Dr. Muhammad, for your presentation.
Thank you.
And I would like to say, and not only I feel misplaced as you, as a pediatric endocrinologist, but I'm really astonished by the male to female ratio in the conference.
Men rights.
Yeah.
We need help too.
Gender neutral.
We need help.
Yes, exactly. And I would like to thank Dr. Osama, of course, for the invitation to be amongst you and co-chair this session of pediatric debates. And not to mention, in one of the most important debates in pediatric andrological issues is hormonal treatment in pediatric urology. So I'd like to invite Dr. Ahmed Al-Dirwi to present to us facts and myths in this area from Asyut University. Thank you.
Dr. Ahmed is one of the eminent pediatric urologists in Egypt and Asyut, and have many good works and many techniques. So I'd like to okay.
It's time to be here. It's good for it is very good that the private sector as well help in the conference education, as well as the university and the scientific committees. I have to thank the scientific committee for the invitation. When I was trained, I usually use a lot of hormones for hypospadias, for undescended testes. But when I visit US for fellowship, the indication was not the same. It was very restricted, not like in Egypt. Also in Saudi Arabia, the same principle. So I have to search, is this very beneficial or it is just a mess? This is the hormones we have, HRH analogs. This is usually for undescended testes to improve fertility, and it is proved. It is written in the guidelines. It is not so available in Egypt. The other thing is HCG. It is usually used for undescended testes, but it is not in the literature. Sometimes it is used for hypospadias as well. Androgen, used a lot for hypospadias, but sometimes it causes complication. Estrogen, sometimes used, especially in France, to improve healing. And as their paper said, it is usually more induce healing, much more than testosterone. So in literature, what we use in Egypt usually, androgen and HCG. The dose for testosterone, systemic testosterone, is 2 milligram per kg every month, and sometimes people go for further escalating doses. Sometimes we use topical testosterone or topical, the active form, dihydrotestosterone, in case of resistance to the testosterone, the regular one. HCG have a lot of schedule. This is one of the schedules used. As in this scientific program, you will discuss undescended testes. I choose to speak about the hypospadias. Hypospadias may be good in most cases, but some cases with micropenis, small glands, penile curvature, reoperation, partial androgen insensitivity, proximal hypospadias, and undescended testes. This is the complex cases where hormonal therapy sometimes recommended by surgeons. And this is survey all over the world. Almost 11% use hormonal therapy as regular and 2% always. But the majority don't use hormonal therapy for hypospadias. And most people use in high volume surgeon because they have the most complex cases. So the benefits may be improve the cosmetic appearance if you use the proper dose. Micropenis become more apparent. May decrease the penile curvature. The question about the need to reduce surgery, we will see later. It is beneficial to prevent complication or not. And the other thing, the improved sexual function after in the adult life. So we all know the hormonal therapy will improve the glands width. And in the meta-analysis, it is 0.3 centimeter. It is durable after 1 year, but we will see it is beneficial or not. The other thing about the penile length, it also increased with repeated dosage. And after 1 year, the average increased length is 0.9 centimeter. So again, it is have some effect. In proximal hypospadias, it is disproportionate response. The urethral plate not respond well to hormonal therapy, despite the proximal part of the penile shaft responds much more. The preputial skin also responds very well, and vasculature become much better. But the bad thing for testosterone that the healing is less, and most people recommend to do surgery 3 months after the last dose. The other extension is the receptors. We all use hormonal therapy without genetic mapping or receptor mapping. For severe cases of hypospadias, there is decreased androgen receptor and increased estrogen receptors. So we give therapy, we got some side effect and no much benefit. And this is what's called androgen resistance. It is in 57% of cases of hypospadias. And those cases not respond well to hormones, and those cases have a lot of complication with surgery. So the role of hormonal therapy in this case is that you tell the parents this case is not respond well to hormones, and the outcome of hypospadias surgery will be much less than expected. And this is the same tip repair with snodgrass for those with small glands. He gave hormonal therapy, increased the glands width, but overall the glands dehiscence was the same. So the complication was the same. And this is the meta-analysis. There is no difference whatever you give hormonal treatment or not to the outcome of hypospadia surgery. Some protection against urethroperitoneous fistula, but the other complication were the same. Also, those who were not responded has a lot of complication, and this is the message we could use or deliver to the parents. What about the side effect? The pubic hair, which is a lot of worry to the family, and also genital skin darkening, post-complication less with topical estrogen, also with HECG. The long-term side effects is not understood. Maybe polycythemia, shorter penile length when he become adult, may affect the bone age, neurobehavioral change, and testicular atrophy. Actually, this testicular atrophy, I saw it like 10 years ago. A case of bladder extrophy, got a lot of testosterone to improve the penile length. Actually, that child lost his testis. So this was the changing moment for me to stop hormonal therapy for these kids, and let's see our practice without it. If I have a case of micropenis, severe one, and after surgery, the penile length is not so good, I usually refer these cases to pediatric endocrine to get the proper follow-up much better than our follow-up. And this is a case of micropenis with small glands. After degloving, it looks much better. And we just do the same degloving, like radical degloving, till the penopubic junction and penoscrotal junction, and get the skin flaps, and the result is good without hormonal therapy. So our message in this lecture, that stop using hormonal therapy for hypospadias except undercover with pediatric endocrine, and the long safety effect is not known. Thank you.
Dr. Ahmed.
Thanks, Dr. Ahmed.
Dr. Ahmed Al-Dirwi. Thank you for this illustrative lecture. I wanted to ask about in cases of proximal hypospadias with severe CORD, when we are planning for a staged repair, when do you prefer to prescribe the hormonal treatment? Before the first stage or before the second stage?
I usually do the first stage as usual without hormonal therapy. I use the natural androgen surge, which was between 3 months to 6 months. I usually start my operation very early at 6 months. And after first stage, if the penis looks not micro penis, I proceed to the second stage without hormonal therapy as well. If it is micro penis, I refer it to pediatric endocrine and see if he is indicated for hormonal therapy or not. And in this case, usually we give the active form of hormonal therapy, dihydrotestosterone, because we expect androgen resistance in these cases.
Do you mean even in hypospadias cases, you refer your cases to the pediatric endocrinology for prescription of hormonal treatment?
Yeah, I never prescribe hormonal therapy since 10 years. Usually I do my best in first stage, and if there is not satisfactory outcome, I refer to pediatric endocrinology.
I totally agree with you.
I'm sorry, just to mention, as a pediatric endocrinologist, the main cause of referral initially, if there is severe hypospadias, so this has to be assessed for DSD, or disorder of sexual development, or if it's mild and moderate hypospadias with micropenis, as you mentioned, or unilateral undescended testicles. So definitely if there is mild or moderate hypospadias with other manifestations like micropenis, the patient should be referred to pediatric endocrinology, and also those with severe hypospadias have to be assessed for disorder of sex development, definitely. And the second cause is, as you mentioned, the hormonal therapy, because I think the doses are different between the pediatric endocrinologists and the urologists. Sometimes we are minded about high doses of testosterone or high doses of beta SCG, because they might lead to closure of the epiphysis and lead to short stature eventually later on. And we see a lot of patients that have advanced bone age because of huge doses of testosterone replacement or even beta HCG. And thank you.
I agree. Most of these proximal hypospadias come to us from pediatric endocrine. So they already got the assessment before, and then we do our surgical part. And this is the same message that I am a surgeon. I don't have to prescribe such hormones.
Dr. Ahmed, what about the use of topical androgens in case of micropenis suffering hypospadias?
Yeah, I agree. It is much safer than the systemic testosterone, but again, I use it after I exhaust myself in the first stage, like in the micropenis. If it is cleared from endocrine point of view, I do my surgery, and then if he still needs hormonal therapy, it is a matter of discussion with pediatric endocrine.
As a matter of fact, it depends according to the cause. So if the cause is 5-alpha reductase deficiency, the patient should ideally receive dihydrotestosterone cream. So it's according to the hormonal profile. Or if partial androgen insensitivity or other causes, could receive testosterone as a cream, as a local, or 25 milligrams to 50 milligrams IM testosterone. So it depends according to the cause, actually.
Dr. Ahmed, the question for you and for Dr. Yasmin, do you think that micropenis is an endocrinological term or a surgical term?
Yeah, I agree. It is mainly endocrine, but we have a surgical part for us. But it is mainly endocrine entity rather than a pediatric urology solo.
دكتور أحمد هو سؤالي in cases with the small glands حضرتك عارف snodgrass has described the 14 millimeter as a diameter. As a routine, would you use hormonal therapy, or you depend on your surgical technique?
Yeah.
In cases not with micropenis or with undescended testes, الحالة العادية اللي بنشتغلها كل يوم.
Small glands, it is like difficult entity. It is usually with normal penis, but the glands itself is very small. According to the paper of Snodgrass, he found that whether you give hormonal treatment or not, you got the same complication rate. So it is better to get like radical dissection of the glandular wings. You have to expose the head of the corpora and go radical. And then you have to convince parents it is not will go like the normal. It will be like glandular hypospadias at the end. So the expectation of the parents should be like treated before surgery, and this is the best you can get.
Thank you, Dr. Derwi. Our next speaker, Dr. Mohammed Fathi, Dr. Mohammed Fathi is the Secretary of the Egyptian Pediatric Surgery Association, and will give us a lecture about the parent penis.
Assalamu alaikum. Thanks for the الذكورة, Dr. غطاس, and all the team. Thanks for the organizing committee, scientific committee, for this invitation and for the conjoining this session with the Egyptian Pediatric Surgical Association. It's me, Mohammed Fathi, Professor of Pediatric Surgery, Mena University, and Secretary of Egyptian Pediatric Surgery Association. And this is, usually this is pediatric surgery. buried penis, a myth to be clarified. So buried penis is a developmental condition in which the penis is normal. I just want to emphasize on this definition of buried penis. The penis usually normal in size, but it looks smaller. It appears smaller, the external genitalia appears smaller, and this is because usually it is retracted in the pubic area. Buried penis is more commonly observed in infants and prepubertal boys. Most patients with buried penises seek medical consultation for the small appearance of the penis or for routine circumcision. Older children may have difficulty maintaining hygiene, resulting in repeated balanitis and urinary tract infection. Some patients also experience difficulty holding the penis during voiding and impressment when naked. It is less than 40% in newborn in Japan. However, it is an increasing issue. That's because of the indoors activities, increasing computer games, increasing junk food, which increase the complaint of obesity, which is one of the most important causes. The condition may be congenital, and it also in adulthood and older children may be due to suprapubic fat. So there we have various etiological factors that explain the buried penis. The most important one is that we have normal anatomy, but the penis is tethered and retracted by fibrous band which is connected to the dartus muscle. Sphenoid suspect that the dartus fascia in most of them is fibrosed, non-elastic, and so it prevents the extension, the forward extension of the penis and hold it buried under the penis. So we can conclude the pathological causes and classify them into pathological congenital concealed penis and acquired concealed penis. The congenital concealed penis, the most accepted theory is the abnormal elastic fibers restrict the penile extension, and this is usually because the non-elastic fibrous dartus muscle, also penile fascia dysplasia or fat accumulation between the dartus fascia and the deep fascia, absence of the root ligaments or weakness of the root ligaments, suspensory and infundibular ligaments, deficiency of the shaft skin, especially in those circumcised patients, one every time circumcision, every time the penis retract, every time circumcision, the penis retract, and we lost most of the penile skin. Acquired concealed penis, obesity is the leading cause. And this is buried penis, even post-circumcision. Misevaluation of this case, consider it a small penis. It is not a small penis. It looks small. However, it is normal-sized penis, but it is retracted in the pubic area. Maybe we misevaluate this penis as having excess skin. Actually, after the penis, after we push back the root of the penis and have the stretched penile lens, we will find that we have less skin, not excess skin. And this is concealed penis after operation. We have to look for this photo webbed penis. We have penoscrotal web, which is considered one of the important causes of buried penis. And this is concealed trapped penis after surgery. We see that surgical scar. And we should emphasize on that photo that every one of may be buried penis after circumcision interpreted as small penis with excessive skin, which is a false interpretation. And we will, that patient will be advised to do recircumcision. In recircumcision, our baby will lose the penile skin like that photo, and this is what is called post-circumcision penile skin loss. And even after correction of the buried penis, we will need for skin coverage, maybe by scrotal flap or by grafts. Parrot penis has many classification. So some classify it as congenital parrot penis, and this is classified into partial and completely parrot, and partial penoscrotal web or complete penoscrotal web. Other classify it as concealed penis, webbed penis. Webbed penis means that we have penoscrotal web, or trapped penis after circumcision or after surgery, and some consider micropenis as one of the classification of webbed penis. But most of classification don't consider micropenis as one of the classification of concealed penis, as micropenis usually is short in size and have hormonal problem, and only hormonal therapy can correct the case. Dr. Ahmed Al-Hadidi, one of the recent and most famous classification of parrot penis, Al-Hadidi classified it into abnormal long inner prepuce. To know what is the meaning of inner prepuce, we know that we have the glands, then the sulcus, then the mucosa. The mucosa, if it is long proximally and then reflect to line the prepuce, this is called the inner prepuce. If we have long inner prepuce, it is considered to be one of the causes of the parrot penis. So Dr. Hadidi classified it as abnormal long inner prepuce, and abnormal long inner prepuce associated with attachment, abnormal attachment of the penile ligaments. The penile ligament is attached distally, so not proximally. So when it's attached to the middle of the penis or the distal shaft, it can retract the penis backward. The third degree of Al-Hadidi classification is abnormal long inner prepuce, abnormal ligament attachment, and excess suprapubic fat. Many complications are associated with parrot penis, including poor cosmosis, poor hygiene, difficult accessibility, and recurrent balanitis, UTI, negative feeling by parents and patients. So the examination of our baby, we will find the penis looks short, however, it is emptied in the pubic area. The foreskin is peak-like or hair-like. The penis skin is relatively insufficiently, usually in after circumcision. The normal penis body is exposed when the skin of the penile root is pushed backward by the hand, and the penis body quickly retracts after release. And the angle of the penis and the scrotum is obtuse. We have to know that we have that angle of the penis, and this is the scrotum, and we have the penoscrotal angle, which usually not more than 110 degree. So if we have it more obtuse, it is considered to be associated with parrot penis. The testicle in parrot penis usually normal in size, and also we have excess suprapubic fat. أنا بس في الصورة دي عشان هرجع هنا عشان نبين الاكزامينيشن على دي. البينس هنا بيبقى ريتراكتد، بيبقى شكله شورت. لو عملت بوشنج على الروت اوف ذا بينس بصوابعي الاثنين هيبدا يظهر معايا، وبعد ما بسيب ايدي بعد ما بعمل الريليز هو بيريتراكت مره كمان. هلاقي احيانا السكين قليل، التستيسس بتبقى دايما طبيعي، وهنلاقي زي الولد ده عنده سوبرا بيوبيك فات واضحه جدا. بس احنا كنا محتاجين ان احنا نوصل لحاجه اوبجكتيف، لان ممكن حد يفسر الولد على انه هو بارد بينس وواحد تاني يفسره على انه مايلد ديجري، فاتعمل لنا حاجه اسمها الكونسيلد اندكس. الكونسيلد اندكس بان انا بقيس البينس وهو بارد زي ما هو، وده اسمه ابارنت لينز، وبعدين اعمل الاسترتش بان انا ارجعه لورا، ادوس عند الروت اوف ذا بينس بايديا، فالبينس هيبقى ستريتشد وهيظهر، واقيسه وهو ستريتشد، واقسم الابارنت بنايل لينز على الستريتشد بنايل لينز. لو هو اقل من او يساوي 7/10 فده كده بارد بينس، واتقسمت الى ديجريز من 7/10 الى 0.5 ده مايلد فورم، من 0.5 الى 0.3 ده مودريت فورم، من less than 0.3 is severe form of parrot penis. ده اسمه الكونسيلد اندكس. وده اللي انا اقصده بكلمه apparent benign length، ان ده الطول اللي هو لسه apparent من غير ما نعمل له الاستريتش. وادي في الثانيه وانا عامل الاستريتش واقيس، لو انا هتلاقي هنا ده حوالي تقريبا لزان 2 سنتيمتر، الثاني 3.5 سنتيمتر. لو انا قسمت دي على دي هتطلع لي النتيجه اللي هي زي ما احنا قلناها، نقدر نقسم بيها هو ده بارد ولا لا، وهو الدرجه بتاعته ايه. طبعا ممكن نعمل سونار نقيس اللينث اوف ذا بينس، ممكن نعمل هرمونال بروفايل في الحالات بتاعه المايكرو بينس. طبعا التريتمنت كونزرفاتيف، في والله في يعني برضو كذا مدرسه في موضوع الكونزرفيشن. في مدرسه بتحب تكونزرف على الناس اللي عندها سوبرا بيوبيك فات في الكونجينيتال كونسيل بين او الكونجينيتال كونسيل بينس لحد البيوبرتي. في مدرسه ثانيه بتقول لا، احنا ممكن نكونزرف اب تو 3 ييرز، لما السوبرا بيوبيك فات ده المفروض ان هو بيخف في معظم الاطفال. لو فضل بعد ما خف السوبرا بيوبيك فات خف والبينس فضل بارد زي ما هو، يبقى اتس ا ماتر اوف ligaments, it's a matter of long inner prepuce, it's a matter of fibrotic inelastic dartus، يبقى ده محتاج سيرجري. لكن لو بالسوبرا بيوبيك فات بمجرد ما خفت العيان اتحسن، فاحنا كده خلاص مش محتاجين نعمل حاجه. السيرجيكال كوريكشن بتاعي بعمله لما يبقى عندي سيفير ستينوزيس اوف ذا اكسترنال بريبيوس، بعمله في السيفير بينايل سكين ديفيشنسي، في البالانايتس المتكرره والديسيوريا واليو تي اي المتكرره، ولو انا عندي مشكله مأثراري على السايكيك او المينتال هيلث اوف ذا تشايلد، وفي حالات طبعا المودريت والسيفير كونسيل بينس. الكونترا انديكيشن طبعا هستنى في الحالات الهايبوسبيدياس. الاول سنات جراس ما كانش بيعمل الديجلافنج للاخر، وبعدين دلوقتي بقى بيعمل الديجلافنج لحد الاخر، وبقى كمان بيعمل فيكسيشن، فبيصلح لو في بارد بينس بيصلحه مع الهايبوسبيدياس. وفي حالات الابسبيدياس ليها طريقه مختلفه تماما. الحالات اللي هي عندها ديس اوردر اوف سكس ديفلوبمنت، او لو عيان عنده انفكشن في المنطقه دي او كواجلوباثي، ده كونترا انديكيتد. الستبس بتاعتي في السيرجري، الستبس بتاعتي كلها بتعتمد على ان انا اعمل كومبليت exteriorization اوف ذا شافت، وده هيتحقق بالديجلافنج اوف ذا بينس. actually we should deglove the penis very far لحد ما نعمل division للليجامنتس اللي هي suspensory وinfundibular ligaments، لازم نفصلهم خالص، وده لوحده may be enough في الحالات بتاع المايل تو مودريت بارد بينس. لكن حالات السيفير ديجري اوف بارد بينس هتبقى محتاجه ان احنا نعمل فيكسيشن كمان مع البيوبيك بريوستيوم عشان نثبت البينس. في بعض الناس بدات دلوقتي تعمل لايبوسكشن او لايبوتومي، وده الصراحه ممكن يحل المشكله بشكل كويس. طبعا لازم الحالات اللي عندها ويب بينس كروتال ويب وي هاف تو دو ان احنا نعمل كوريكشن للويب ده، بان احنا نعمل بقى باي طريقه بقى، بالذات بلاستيك بالام بلاستيك بالبيكوليكس، اي طريقه نعمل بيها نفك بيها الويب بينس ونعمل اسكروتو بلاستي ونريكونستراكت البينو بيوبيك انجل. طبعا احنا بنعمل لها ريكونستراكشن بان احنا نفكس باريوريثرال عند الساعه 4 والساعه 8 فنترالي، ده هيعمل لي بينو بيوبيك انجل بشكل كويس. وطبعا في الاخر الكفرنج اوف ذا شاف، لو انا عندي في سكين كويس هقدر ان انا يغطي لي البينس، هقدر لو ما عنديش لازم ان انا الاقي سكين كفر، ما سيبوش كده، او ان انا لان انا لو رجعت شديت الجلد تاني وخيطته بعد ما كنت عملت الديجلافنج ما انا هرجعه لورا تاني، فانا لازم يبقى عندي سكين كفايه. الحالات اللي هي لسه نون سيركمسايز انا بقدر احدد الجلد ده، ما بشيلش غير لما بقدر احدد الجلد بتاعي. الحالات اللي سيركمسايزد قبل كده واحنا عندنا مشكله في السكين كفرج، ممكن ناخد لها سكروتال فلابس او ناخد لها جرافت. ده الكومبليت ديجلافنج اللي احنا عملناه لوحده اتصلحت، ودي اللي انا كنت اقصد بيها ان انا لازم اشيل الفايبروتيك دارتوس ماسل، وده كان الابارنت بنايل لينز. وبعد ما عملنا الكوريكشن المره دي انا مش شادد البينس بايديا ولا حاجه، هو البينس بعد الديجلافنج والفيكسيشن قدر يجين اللينس بتاعه، وبقى ده الكوريكتد بارد بينس. انا خلاص الكونكلوجن بتاعنا ان البارد بينس از نورمال اللينس، هاويفر ات لوكس سمول عشان هو بيبقى ريتراكتد. ماني كلاسيفيكيشن موجوده للبارد بينس، اكتر حاجه فيهم اللي احنا بنقولها اللونج انر بريبيوس بتاع ان الميكوزا بتاعتنا طويله قوي، وكمان معاها ان الليجامنتس نفسها فيها مشكله، وكمان اللي فيه اوبيسيتي. الباريت بينس ليه كونسيلد، وده مهم جدا. الكونسيلد اندكس بان احنا بنقسم الابارنت لينس على الاستريتشد لينس واحدد هو بارد ولا لا والديجري بتاعته ولا لا. الديجلافنج في العمليه في السيرجيكال مانوفر، الديجلافنج از ذا موست امبورتنت to be done، ومعاه الفيكسيشن في حالات السيفير. Thank you very much. Thank you.
Thank you, Dr. Mohammed, for this nice presentation. Any questions from the floor?
Thank you.
Thank you, Dr. Mohammed. Thank you. This is we are at the end of this session, and we invite the chairperson for the next session. دكتور أحمد العاصمي، دكتور حسن أبو العينين، دكتور أسامة غطاس، دكتور شريف مراد، دكتور سلطان فخري. Okay, sorry. We'll start opening before this session.
Thank you all for this great discussion. And now, we're honored to welcome the Medical Director and Head of Scientific Committee of Dar el-Zukura Group, who is truly the guiding force, the shadow behind this conference, ensuring that every detail reflects excellence, whose expertise ensures the high scientific standards of our conference. Please help me welcome Dr. Abdelmenaim Goma on stage.
Dear our guests, my colleagues, good afternoon, everyone. It's a pleasure for me to stand here in front of you to present Dar el-Zukura, the success story that we believe in. We are all agree that everything begins with an idea. The idea behind Dar el-Zukura started many years ago with Prof. Osama. He started with 3 questions. How can we do the andrology better? And how can we serve patients in a different way? And how can we raise the standards? And he started to search for the standards. We are not just a medical center. The patient used to enter as a patient and leave us when he is a friend with us. We have a specialized concept regarding andrology, and we have a clear medical philosophy in a view of medical protocols. And we have a long-term vision for follow-up and being in contact with our patients. The success is the choice, and we started our choice with a team and motivation that results in success. We have a focused specialization on our patient regarding andrology, and we have no shortcuts. We are using the time to reach our goals with continuous improvement for every step, with our audit for everything that we do, starting from the medical files, from the protocol, for everything. And our growth with a purpose. We have expansion when it was in need. We have no random expansion. We have a quality before quantity. And we have same standards in everywhere. We have a protocols with a clinical audit and revising everything. And we have our own team, more than 250 working personnel together, more than 50 medical staff, consultants and residents and specialists, of course. Our footprints today can be summarized in 6 branches in Egypt: Smoha, Miami, Mansoura, Mohansin, Tajammu, and also in Zayed. And we have 3 branches international. And we are going to open the 4th branch recently. We are working beyond borders. We have patients from different countries. Referral center for complex cases is Dar الذكورة. And also we have international trust. As we believe that education matters, we started to think about medicine. That we know that medicine is always evolving, and experience must be shared. And knowledge creates sustainability. So we have DZAC 1, 2, 3, and we are honored to be together today in DZAC 4. And from experience, from our practice, we started to think about teaching. We started with workshops, live surgeries, and scientific meetings, even medical meetings. We have a scientific monthly meeting, and we have real hands-on training. And finally, we have a new global step, a registered International Society for Surgical Uroandrology, born from real clinical experience and built for the future with a group of the most eminent personnel working in the branch, and even connecting surgeons worldwide together. What International Society for Surgical Uroandrology represents? It represents education, purpose, and we have innovation inside it, and we have standardization and also collaboration with others. Our mission is to modernize surgical education and to empower young surgeons, and also to bridge science with practice. The future we see from our place now is we are going to have more global expansion, and we are going to be stronger regarding the education platforms and the worldwide scientific community. Our final thought that we are usually speaking about, that we don't aim to be in everywhere, but the aim to make a difference wherever we are there. I should say thank you, but please wait. I have another twin, another mirror image, a new brother in our steps towards excellence. This step should be presented by my colleague, Dr. Amr Mohsen, if he please.
Good afternoon. It's a pleasure to be here with such talented group of colleagues. I am Dr. Amr Mohsen, consultant urologist and head of urology department at Ministry of Interior's medical sector. I am very excited to announce the opening of Dar al-Masalik, a new specialized center in urology. This project, launching under the leadership of Dr. Osama غطاس, who has entrusted me to lead the center as executive director. While Dar al-Masalik is a completely independent entity, we are proud to follow the high standards set by Dar al-Dhukura Group. They are our benchmark for excellence in clinical care and research. We value your partnership and look forward together to working together, accepting your referral and sharing scientific insights to improve patient care. And here is a concise overview of our specialized service and distinguished medical team delivering this care. Our vision is to deliver evidence-based, high-quality urological care through expert urology consultants, and to become a regional reference center in urology by integrating advanced diagnostic, minimally invasive interventions and continuous medical development. Our organizational structure will form of the COO, which will supervise three main sectors: clinical departments, medical support team, administrative and patient service department. Clinical departments, the center operates through distinct clinical departments designed to provide complete coverage of diagnostic and therapeutic urological service for all patient categories. Our clinical departments will be five main departments: urology clinic, proctology and anal surgery clinic, nephrology clinic, physiotherapy and rehabilitation clinic, and diagnostic unit. The urology clinic will be supported by urodynamic unit and diagnostic cystoscope unit. The urology clinic will be operated by three talented consultants: Dr. Ismail Futuh Radi, consultant of urology and head of urology department at El Aguza Police Hospital; Dr. Magid Mustafa, urology consultant and head of urology department at New Cairo Police Hospital; and Dr. Mohammed Al-Bagouri, consultant of urology in police hospitals. Proctology clinic will be operated by two talented consultants, Dr. Magid Abdullah and Dr. George Ibrahim. Both are consultant of general surgery and laparoscopic surgery and head of general surgery department in police hospitals. Nephrology clinic will be operated by Dr. Muhammad Ali, who is a consultant and lecturer of nephrology, renal transplantation, and diabetes at Ain Shams University. Physiotherapy and rehabilitation clinic will be operated by Dr. Maher Khalil Ibrahim, Dr. Samuel Abdel Mesih Ibrahim, Dr. Muhammad Tariq Hafnawi. All are physiotherapy consultant, Cairo University. We have two diagnostic units, ultrasound clinic and on-site clinical laboratory. The medical support team will consist of consultants and professors, the high level of clinical oversight, specialists and resident, nursing and technical staff. Administrative and patient service will be formed of patient coordination office, operation and quality control, front desk and admission. Let's elevate patient care together. Thank you for your time and trust.
Thank you, Dr. Abdul Menam and Dr. Amr, for your talk. With such inspiring leaders guiding us, it's only fitting that we take a moment to recognize and honor those whose hard work and dedication make this conference possible. We now move to our appreciation ceremony. Please let me welcome Professor Dr. Osama غطاس, Professor Dr. Hassan Abul Unain, and Professor Dr. Sharif Murad on stage to present the award shields to those we genuinely convey our gratitude for this participation in Dar al-Dhukura Conference Hall.
Let us welcome one of the leading surgeons in the Italian field of andrology, a urologist with over 10 years of experience, with a continued collaboration between European centers and the United States of America. Please help me welcome Dr. Gabriele Antonini on stage.
He is a senior consultant urologist with over 29 years of experience and a German board certification 2003, and the head of the urology department at the Royal Bahrain Hospital. Let us welcome Dr. Rifai Masoud on stage.
The Director of the Department of Andrology and External Genital Surgery at the University of Foggia. Please help me welcome Dr. Carlo Bitocchi on stage.
The Executive Director of Arab Association of Urology and the President-elect of Society International of Urology. Let us welcome Dr. Yasser Farahat on stage.
The Director of the Department of Andrology and External Genital Surgery at the University of Foggia. Please help me welcome Dr. Carlo Bitocchi on stage. He has a medical doctor degree from Turkey and has completed a residency in urology. He is working in the EAU Sexual and Reproductive Health Guidelines and at Brunei University School of Medicine. Please help me welcome Dr. Ij Khan on stage. Arab Association of Urology, President of Oman Urology Society, and Chairman of Research Committee for Oman Urology Residency Program. Please help me welcome Dr. Mohammed Al Marhoun on stage.
He's the president of the Medical Syndicate of Al Bahira Governorate. Please let me welcome Dr. Ahmed Zaghloul on stage.
And President of the Egyptian Urological Association. Please help me welcome Dr. Hassan Abu Al-Ainain on stage.
He's a consultant of urology and the Secretary General of the Egyptian Association. Let us welcome Dr. Sharif Murad.
Urologist from Alexandria. Please let me welcome Dr. Sultan Fakhri on stage.
He's a consultant urologist from Alexandria. Please join me in welcoming Dr. Muhammad Uthman on stage.
Let me welcome our guests to take a photo on stage.
And now, before we continue, we would like to invite you to watch a short film about Isis.
The pharaohs believed that there was a god of the earth named Geb and a god of the sky named Nut. Geb and Nut got married and gave birth to 4 minor deities, namely Isis, Osiris, Set, and Nephthys.
Does Set mean a woman?
Oh no, that's his name. Don't interrupt me again.
All right.
The pharaohs didn't have problem with siblings marrying each other, so Osiris married Isis and Set married Nephthys.
Nice.
Set, being jealous of his brother because he was a just and beloved ruler, wanted to get rid of him and rule in his place. He organized a grand celebration and invited his brother Osiris. At the party, the guests found a luxurious golden coffin, with Set announcing that it would be a gift to the first person it fitted perfectly. Set had made the coffin to fit his brother exactly. So, each person who tried to sleep in the coffin found it not fitting them until it was Osiris's turn. As soon as he lay in the coffin, Set closed it and threw it into the Nile.
Really?
Yes, for sure. As I tell you, Isis learned about what happened to her husband and insisted on searching for his drowned body. As soon as she found it, Set kidnapped the body and cut it into 42 pieces, distributing them across all of Egypt's governorates.
Oh my God.
Isis did not give up, and she continued to wander throughout all of Egypt, my dear, to gather the scattered body of Osiris.
Good.
No, not good.
Why?
There was a missed part. She couldn't found it.
Which one? Which part couldn't she found?
A very important part.
Which is it?
The most important part in male's body.
Where is it?
The part in which the male can't reproduce without it.
Which?
That it, Mosen. This part, can you see it?
Yes, all right.
Then, Isis took her husband's scattered body to Anubis, the god of embalming, and asked him to restore her husband so that she could conceive from him. Anubis told her, yes, all right, but how will you conceive from him when this part is missing?
That's right. Then?
Isis thought what to do. Then she went to Dr. Osama Gattas. He put a penile implant to Osiris that was very nice.
Really?
The penile implant worked efficiently, and after a few months she was pregnant and got birth to Horus.
That's so nice.
And Horus grew up, and by the grace of God, he became tall and robust. He decided to revenge from his uncle, Set. He successfully managed to confront him and took over the rule of the country, and that was all.
We will now move to our next session, Plenary Session Part 1, Advances in Erectile Dysfunction from Therapies to Latest Advances, in collaboration with International Society of Surgical Uroandrology. Please let me welcome the chairpersons on stage. Professor Dr. Ahmed Al-Assimi, Professor Dr. Hassan Abu Al-Ainain, Professor Dr. Osama غطاس, Professor Dr. Sharif Murad, Professor Dr. Sultan Fakhri.
هنبدا دلوقتي بالدكتور هنبريزنت دلوقتي دكتور جابرييل. تمام؟ بعد كده دكتور اسامه وبعد كده دينز ودكتور سمر عشان دول ريكوردرز فعلى حسب التايم هنقدر نشوف هنقدر نشغلهم ولا لا. اه تمام.
Good afternoon, everybody. It is our pleasure to be here with you in this magnificent meeting. And as I remember, when I was a young resident, I listened to the late Professor Badr. He was the one who created urology in Egypt many years ago. And while we were young residents, he said that the very important organ in the body is the penis. And I can say that man is a penis. And man without penis would be something nothing. It was a big wisdom from an old professor, and then it is now a reality, not from now, but since very, very old ancient times. So this is plenary session part 1. We will come to listen to Professor Gabriel Antoni. he would tell us, as he has the vast experience in the field of andrology and prosthesis implantation, he will talk to us infrapubic approach for benign prosthesis implantation, a surgical technique review. This man is a unique man in his invention and his techniques, and always he has a new and newly born ideas in the field. Please.
Thank you very much for the invitation. We are developing with Professor غطاس a new center of excellence here in Egypt and also in Italy, because we want to develop much more as possible the penile implant with the pinoscrotal and the infrapubic approach. I'm going to present the infrapubic approach, the technique. We can go ahead with the video. We start. Okay, very important is the position on the bed. You have to break the patient because otherwise it's impossible to make the dilatation during the procedure. We start with the erectile hydraulic erection, and we check if the patient has any deformities of the penis and some fibrosis with hourglass defect. We put normally 2 stitches following the Perito technique, but now I prefer to put 2 stitches more in each corpora to close better as possible the corporotomy. It's very easy with this approach to implant the reservoir in the spacious in the space of radius, and then we start with the implant of the cylinders. We are using a Rigicon device. It's very comfortable for this kind of technique, and the rigidity at the end of the procedure is very, very good for the patient. This instrument, the nasospeculum dilator, is very important because we don't open too much the corpora. We dilate with this instrument the corpora, and we implant the 2 cylinders with this minimal incision on the infrapubic part. The rigidity of the penile implant is very satisfying for the patient. And normally, to implant the distal part, we use some paraffin or jelly. At the end, we implant the pump in the scrotum. It's very easy. The pump is behind the testis, posterior, and it's very difficult to check the pump after the procedure and during the sexual intercourse. We put the drain inside the scrotum. We keep inside the drain normally for 3 days, sometimes with a vascular patient, with a younger patient, 4 or 5 days. The patient doesn't feel pain, can touch without any discomfort the scrotum, and can start the rehabilitation after 1 week, because for 1 week we keep inflate the prosthesis in order to make an hemostatic work, and then after 7 days the patient start with the cycling. This is a patient with a dorsal curvature 100 degree. We make always the same procedure. We open the infrapubic part and we make the scratch technique. Normally, we use the scissor to break the fibrosis. Sometimes we use the knife inside the corpora when the fibrosis is very, very strong. At the end of the procedure, we close the procedure with the modeling maneuver. This is the result after 2 months. The patient start with the cycling after 1 week, and after 2 months can have the penis completely straight. This is another patient after radical prostatectomy and several injection of alprostadil. We make always the scratch technique. In this patient, we use only the scissor, and this is the result after 1 month. It's very important the time, because if you implant the prosthesis in only 15 minutes, you prevent the risk to have complication and infection. The most important question normally are the fat patient. Is possible doing the fat patient with infrapubic? Yes. Look at this 130 kilogram patient with a big belly. If you put the patient in the correct position on the bed, you can perform without any problems the infrapubic approach. This is the result after 1 year. The patient can touch the pump without any discomfort. Everything is very, very occultate inside the scrotum. It's impossible to see the tubes, and the patient is very satisfied. This is another patient with Peyronie disease. We can manage even the Peyronie disease with the infrapubic approach in the fat patient. You can see we break the fibrosis with the scissor. We implant the reservoir. We need a longer nasospeculum retractor with the fat patient, because otherwise it's impossible to reach the radius space. This is the result after 4 days. The drain is inside, no hematoma, and look at the stitches. After 1 week, the curvature is almost correct. It's very easy with this approach, implant in the ectopic position the reservoir in patient with previous hernioplasty repair surgery or after radical cystectomy. The other question is the neurovascular bundle, but you have in the opposite side with the pinoscrotal the urethra. In the dorsal part you have the neurovascular bundle. This is our video published on VPJU, developed with Federico De O and Paolo Capogrosso. We are using the indocyanine during the procedure in order to show better as possible where is the neurovascular bundle, and we avoid the neurovascular bundle. This is a case of revision after mechanical failure of the prosthesis. We are doing, we treat even this patient with the infrapubic. It's very important, no pinoscrotal and infrapubic, because you can switch from the pinoscrotal to the infrapubic and to the infrapubic, and from the infrapubic to the pinoscrotal. But if you haven't the pump, if you have to implant only the malleable prosthesis, why you have to open the scrotum. With the infrapubic approach, you can implant very, very easily without touch the scrotum, the malleable prosthesis. This is the result after 1 year. And sometimes with the pinoscrotal, this happens. The pump is under the skin, the tubes are very visible. This effect is the Maserati effect. No. Sorry. No. Come back, please. Okay. Okay. You can see we have a problem with the video. I have the video in my pen. The video. Probably there is a problem with the audio. We have 3 minutes to show. In the opposite side, check the video. DZAC, no audio, please. Can you open the video, please? The video on the pen is DZAC, no audio.
Dr. Gabriel,
yeah.
When they have to repair the video, I have a question for you. According to the optimal timing of implantation of the prosthesis after radical pelvic surgery, if it is radical prostatectomy or radical cystectomy and we would need to fix a prosthesis, which is the optimal time to do it safely?
I think if you are very quick, normally we are doing this procedure in 15, 20 minutes, you can prevent the risk to have an infection. Obviously, with the patient after radical cystectomy, you have to put the reservoir in the ectopic position if you can, or otherwise you can use the prosthesis with 2 components, with 2 pieces. The new one from Rigicon, we are waiting for the new one for many patients treated after radical cystectomy. I think, but I think that the time is the best way to prevent the risk to having the infection. Longer is the time, more is the risk to develop an infection. Can you open the video, please?
My question is when to do it. The question is when to do it after the primary surgery of a radical pelvic surgery, 1 month, 2 months, few weeks, 1 year, after how long from the date of the surgery?
But normally now, at the moment, in the video I explained very well, we are doing at the same time radical prostatectomy and implant of the penile prosthesis, but not with the pinoscrotal approach, because with the pinoscrotal you can improve too much the risk to develop an hematoma on the scrotum and an infection, but we are doing this with the infrapubic approach, with a little incision in the infrapubic part, is 1 incision more with the robotic approach. We are doing a little incision of 2 centimeters, and we are very comfortable in this moment with this kind of treatment in young patient with erectile dysfunction before the radical prostatectomy. We explained very well that radical prostatectomy can give to the patient erectile dysfunction, and if the patient is agree, in a good time and in good hands, we can solve the true problems at the same time.
But this is good.
But normally I suggest after radical prostatectomy, after 6 months of rehabilitation, if the patient doesn't respond to the pills for the erectile dysfunction, the best solution to prevent the losing of length of the penis is implant the penile prosthesis.
But this is quite acceptable for radical prostatectomy because the incidence of infection may be less than in case of radical cystectomy. I think we are using bowel, we are using new bladders, and the potential risk of infection is much higher.
Yes, for sure. We are doing now only radical prostatectomy. We haven't any experience on cystectomy. Probably in the next future we can use the two pieces from Rigicon to treat this kind of patient without the reservoir, because if the patient has a new bladder inside, probably the risk to develop an infection is very, very high.
And the minimum time to wait after surgery is 6 months, 1 year more or less?
In my experience, 6 months is enough, because if the patient is very motivated and want to have again a normal sexual activity, the best way to solve the problem is the penile implant.
That's good. Is the video is ready now or not working?
No, there are problems with the video. Okay.
Yeah. Please continue. Is it finished, the lecture?
Without the video, it's impossible to explain. Yes, I think at the end of my presentation, it's very important in this moment, in the historical moment, knows all the technique, subcoronal, pinoscrotal, and infrapubic, because many surgeons are switching their technique to infrapubic. If you have to do a revision of an infrapubic penile implant for mechanical failure, for example, if you don't know very well this kind of approach, you can have a lot of problem. And if the patient has 2 or 3 previous implants with the infrapubic, if you haven't the possibility to switch to pinoscrotal, probably will be very difficult to treat again the patient with the infrapubic approach. In a good center, in high volume center, I think today the best implanter needs to know both the approaches.
Thank you, Dr. Gabriel. May I ask you about this very nice technique? What are the possible or potential hazards or technical problems that can face a surgeon doing this technique?
But obviously, you need a good experience. I say every time you have to start with pinoscrotal. Pinoscrotal is the basic. If you have a good experience, minimum 50, 60 implants with pinoscrotal, you can switch to infrapubic, because you are working in a little space, only 2 centimeters. If you haven't a good experience on penile surgery, on pinoscrotal for the dilatation of the crura, of the distal part, in a little space, you can have a lot of problems, because it's very difficult to identify very well the tunica albuginea if you don't recognize quickly the tunica albuginea. And you know very well the corpora starts with the bleeding in the younger patient very soon, and with the bleeding inside a little space. If you don't know very well the technique and the steps of the technique, you can have a lot of problems. Imagine, I told yesterday to Professor Gattas, I started 17 years ago with this approach, and now, today, I'm growing up, because every day I'm learning something new with the infrapubic approach. Imagine a person that starts alone. I don't suggest to start alone. It's better start with some expert in front of you. But imagine, I have seen many procedures with infrapubic approach, with urethra injuries, with crossover, many problems, with infection, obviously.
Any questions from the floor?
Hello, thank you for this nice presentation, Gabriel. I want to ask you one question regarding redo surgery. If one patient coming to you with penoscrotal approach and you want to do redo surgery, are you going to do infrapubic or you go back to the penoscrotal approach?
No, repeat, I didn't understand. Sorry.
I mean, if one patient coming to you for redo, to remove the implant, you insert a new one.
At the same time or after
no,
time?
after time, because of the infection or mechanical failure or whatever. If the approach at that time penoscrotal,
yes.
Are you going to change it infrapubic or you go back to the...
Okay, perfect, I understand. I always doing the infrapubic for all the patient, but I can do penoscrotal in the same way. Imagine I had a patient with an extrusion of the cylinder with the after infrapubic approach because the tunic albuginea was very soft and the patient had an aneurysma on the tunic albuginea in the infrapubic part. I moved to the penoscrotal for the reimplantation. I removed with the infrapubic the past, the old implant, and I reimplanted with the penoscrotal. I think if you have the ability to switch from infrapubic to penoscrotal or to from the penoscrotal to infrapubic, you are probably the complete surgeon, implanter surgeon. But normally I'm doing infrapubic, you know. We have done many together.
Any further questions from the floor? So you have mentioned to us in your advice that the surgeon should learn more than one approach to solve different problems and different presentation, different complications to control it. What is your advice for the beginners?
The advice is to start with the penoscrotal. To start with the penile surgery, making congenital curvature, revision of phimosis, of circumcision, having a good experience on penile surgery, managing very well the corpora and the tunic albuginea. Then you have to start with the penoscrotal. If you are starting, you can start with the infrapubic. You need a good experience with penoscrotal. And in my personal experience, I remember I have done more than 100 implants with penoscrotal. In Italy, it's not easy, like in Middle East, making many implants, 1,000, 1,500, and so on. But the correct number, in my personal experience, is between 50 and 100 implants before starting with infrapubic. And I remember the first time that I had the infrapubic approach in Italy, I had many problems, bleeding from the bladder, many complications, and in the same night I have to remove the prosthesis. This is my first infrapubic approach. I come back to Miami to visit Perito, and I asked him some tick and trips, and then I restart in Italy. But it's not very easy if you haven't a good experience on the management of tunic albuginea and corpora cavernosa.
See, the last point is that we know that this technique might be associated with some problems, and maybe the issue of medical-legal problems. How can you consent your patient about the potential complications and how he can be satisfied at the end of the procedure?
I think the only complication is similar to the penoscrotal, is the risk to develop an infection, because the damaging of neurovascular bundle, if you have experience on the penile surgery, is impossible, because the tunic albuginea is white. If you feel confident with the tunic albuginea, if you recognize very well the tunic albuginea, you can have any problems with the neurovascular bundle, and the patient knows very well everything before the procedure, like in penoscrotal approach.
Thank you very much for this nice elaboration.
Sorry for the video.
And thank you.
Thank you, Professor Gattas.
Thank you so much, Gabriel. So our next speaker will be Dr. Osama غطاس and the غطاس modification for easy reservoir implantation.
Hello, everyone. Today we will present the first case performed using غطاس modification reservoir performed last years. Inflatable blind procedure established as a case surgery intervention for erectile dysfunction. A steady rise in the popularity over recent decades. 50% of all implants in the United States in the period between 2005 and 2012 were inflatable penile prostheses. The reservoir implantation is the most critical step in the three pieces inflatable penile prosthesis implantation. There is two sites for reservoir implantation. Retropubic, which is standard, and ectopic. Risk of faulty placement of ectopic reservoir resulting in displacement or subcutaneous positioning, visible bulging, disfigurement. To reach to the ectopic site, we retract external inguinal ring to create a submuscular pocket under scarbus fascia. Introduction of novel modification to standard inflatable penile prosthesis implantation technique focusing on reservoir adjustment to enhance safety and outcome. The concept: introduce a small attachment site at the top of the reservoir design, allowing connection of the guiding thread similar to the standard technique using for prosthesis rod itself. The thread is attached to the furrow needles, enable controlled and accurate guidance of the reservoir during placement. This is the shape of the new reservoir. There is an attachment site at the top of the reservoir. Surgical technique workflow. Dissect some muscular space, insert a furrow needle into the prepared space, pinch skin at the exit site, pull the reservoir into the final positioning using guiding thread, verifying reservoir placement and remove thread if stable. Optionally, secure reservoir by making a small incision at the exit point, tying the thread beneath the skin to prevent slipping or displacement. Close the wound with standard sutures. What is the advantage of this modification? Simplify reservoir placement for younger or less experienced surgeons, streaming workflow, faster implantation, lower infection risk associated with reduced surgical durations. Surgeon experience is the key determinant of infection and reoperation rates. The modification can help standardize the technique and minimize variability. What is the patient benefit? Enhancing post-operative recovery, stable reservoir positioning, reduce the risk of movement or tube rotation, and prevent displacement, leakage, and fluid blockage. Clinical implication may accelerate recovery and reduce complication. Next step, prospective studies are warranted to validate improvement and in learning curve, infection risk, and recovery outcome compared to standard methods. Now we will see short movie to the idea.
Says for younger generations of doctors. Currently, there are two main categories of In the medical field, Dr. Osama Gattas and his team have developed a revolutionary design for inflatable penile prosthesis. And it will make inflatable prosthesis implantation an easier process for younger generations of doctors. Currently, there are two main categories of prostheses, malleable and inflatable. Despite the time-consuming steps and difficulties involved in reservoir and pump implantation, the inflatable penile prosthesis offers a more natural functionality, as it can be easily inflated and deflated before and after sexual intercourse. When performing ectopic reservoir implantation for the inflatable penile prosthesis, surgeons have to dissect into the submuscular space of the abdominal wall above transverse fascia and insert the reservoir using an ovum holder. The reservoir is then filled to keep it in place. Although this technique has a higher success rate, there are potential complications, such as hernias or intramuscular insertion, that can occur. Additionally, patients may face a higher risk of reservoir movement after the surgery. Dr. Gattas has addressed these challenges by creating a new prosthesis that simplifies the implantation of the reservoir, as it incorporates adding a surgical thread attachment site to the top of the reservoir. To guide the reservoir to the submuscular space, the surgeon can fix a surgical thread to the site using a needle loaded onto the furlough surgical tool. The furlough technique offers a smoother and more precise positioning of the reservoir, in contrast to traditional implantation methods. After the reservoir is in position, the thread can be removed in the same manner as during cylinder implantation. The thread can also be used to fix the reservoir in its position. By making a small incision at the exit point of the thread, and then the thread is tied beneath the skin to secure the reservoir in place and prevent it from slipping or moving. The wound is then closed with surgical stitches.
اللي هنشوفه دلوقتي يا جماعه دي اول حاله عملناها بالتقنيه ديت السنه اللي فاتت في الورك شوب اللي كان على هامش مؤتمر دار الذكوره الثالث. طبعا في شركه دعامات صممت لنا الخزان بالشكل اللي حضراتكم شايفينه ده. Thank you.
Thank you, Dr. Osama. Any questions from the floor for Dr. Osama?
How many cases now you have done so far of this technique? Just one. So this is a preliminary results. So we have to wait for reproducibility and to repeat it again just to make sure that everything will go without any problems or complications. Yeah. So the next presentation will be in pre-recorded lectures. The first one will be about benign corrective surgery with innovative FDA-cleared implant, subcutaneous benign implant by Jim Ellis. If the lecture is ready. المحاضرة جاهزة؟ Okay, I think the lectures are not ready, so we have to finish this session, and we have a coffee break? Or? Yes, we have to move for the coffee break. Thank you very much. Thank you.
Hello, test mic test. Hello, test mic test. بسم الله الرحمن الرحيم. 1 2 3 4. Hello.
الله الرحمن الرحيم. Check sound. Check sound.
Hey, hello, hello. Hey, hello. 1, 2, 3, 4. Hello. Hey, hello. Hello. بسم الله الرحمن الرحيم. Hello. 1, 2, 3, 4. Test mic test. Test mic test. بسم الله الرحمن الرحيم. 1, 2, 3, 4. Hey, hello. Hello, hello. 1, 2, 3, 4. بسم الله الرحمن الرحيم. Test mic test. Test mic. 1, 2, 3, 4. Hello, hello. Good. Nice.
تمام. فاتح؟ افتح كده عندك وجرب. مفيش؟
ايش اتكلمت ولا ايه؟ هلو. هي هلو. هلو. 1 2 3 4. خلاص انا كنت بعد الكابل بس. هلو هلو 1 2 3 4. هي هلو. هلو. تمام. ايه؟ Hey, hello. 1, 2, 3, 4. Hey, hello. Hey, hello.
I hope you enjoyed the break. We will now resume the scientific program with our next session.
We will now proceed to session number 3, which is a continuation of the previous one, Pulmonary Session Part 2, Advances in Erectile Dysfunction from Therapies to Latest Advances, in collaboration with International Society of Surgical Uroandrology. Please help me welcome on stage the chairpersons, Professor Dr. Ahmed Zaghloul, Professor Dr. Amr Abbasi, Professor Dr. Amr Abu Faddan, Professor Mohammed Al Marhoun, Professor Salah Zidane.
or 2 hours to make expansion of the, because after time maybe you get up to 1.5 to 2 centimeter extra length. When we are going to, if there is any complications, the patient should contact the department or the OBD. If there is fever, if there is pain, swelling, or any drainage, or any significant bleeding from the wound site, or inability to urinate, or the bump cannot be seen or cannot be touched, maybe it's migrated. So in all these situations, you should contact the surgeon or the department about that. Resuming the normal activity, as I mentioned, that 6 weeks after surgery, ejaculation is not affected according to long-term expectation. Satisfaction will start slowly, but after 3 to 4 months, the patient will get the full satisfaction. Adjusting the device, it can sometimes become comfortable and confident when you are using the implant. So more practice and more patience, it gives more satisfaction. So this is the summary of the post-operative, but now I have some cases. Just I have to mention to you about the complication from the literature. It's the infection up to 4%. When there is a revision, it's up to 10%. Also, we have to think about corporeal perforation is 5%. Scrotal hematoma, we have seen many cases, but it represents only 1.3%. We have to know about this, either the superficial infection or deep infection. When it's superficial, it's just to treat it conservatively. When it's deep infection with the sign of sepsis and other things, in this case, maybe we think about the removal of the implant and to drain all the infected areas. Also, there's another thing that like if it is deep infected benign prosthesis, usually it can occur in the first year, particularly first 3 to 6 months after surgery. So it's very important to differentiate between acute infected benign prosthesis or chronic. The acute, usually there is a picture of sepsis with fever, while the chronic, there is no picture of sepsis. Just now I have some cases to show to you. On right side, there is early presentation less than 8 weeks from surgery. So in this case, so direct because there is a sepsis picture, also a collection in the scrotum. So directly we have to drain that one and we remove the implant. The other one on the left side, there is a chronic infection more than 8 weeks. You can differentiate that by the bump. It is fixated to the scrotal wall. But when you do blood test, you cannot see leukocytosis or elevated C-reactive protein. Also, this one acute case, like this one, there is drainage of pus. The other case is the chronic one. Okay, this is some cases what we have seen in our OBDs. The first one, it's 1 week after malleable benign prosthesis. There is edema. In this case, you do nothing, just you go for conservative treatment. The middle one, the patient came to me before 2 weeks in the OBD with this picture. Before 3 months, he has underwent malleable benign prosthesis in other country. So just we remove that one and we insert catheter because this is perforating even the urethra. So just we give time. So after maybe 3 months, we have to think about a revision for this case. So still we have one benign root of the malleable implant, and the other one is removed. The third one also there is the malleable implant is after 1 year. It is not inside the corporeal body, so that means it needs also special surgery to create a new cavity to put the implant inside. These other 2 cases, I think the time is, I have other two cases, but okay, anyhow, if there is any question. So still I have some pictures, need maybe less than 3 to 4 minutes. Okay, thank you. Can I resume that one? It's not possible. Okay, thank you very much.
No. Thank you, Dr. Rifai, for this nice presentation. There is questions from the floor. So
Dr. Rifai, thank you very much for interesting lecture. I wish you comment on the last picture, the necrosis, which is a very important complication. And then I have a question for you. My question is, what do you think about benign Doppler as a tool in the preoperative assessment?
Benign Doppler, we are using that, but not routinely. If somebody is coming after radical prostatectomy, after 1 year, so we are not thinking that he will get benefit from that one, so we go direct for implant. Usually we do benign Doppler ultrasound for those young patients who are thinking about the psychological cause, not organic cause. But when I consider in my OPD, if I see 10 cases they have erectile dysfunction, I think only 3 of them, I send them for benign Doppler.
In fact, if I may just add to this, one way I think about the benign Doppler, not only diagnosing arterial insufficiency, but also, uncovering the unknown. Some patients, especially in our region, they do not tell you if they have Peyronie's disease, or they may not even know about it. And in fact, we discover it during the benign Doppler, and we assess the degree and the severity. This really helps you to plan your surgery. This is one way.
Regarding this Peyronie disease or enduratio venous plastica, in these cases you can examine these cases during the OPD. Patient, he can give you some pictures if there is any deviations with different angles. I think, okay, the benign Doppler can help you also about the blood supply at that plaque areas or at the fibrotic areas. But in some cases, when it's doubtful, like with fibrosis, either we will go to treat the fibrosis or the Peyronie disease, or to go for implant. In this case, I agree with you to go for benign Doppler.
Okay. There is another question. There is any rule of conservative maneuver or conservative in glands ischemia, or you have to, once it happened, you have to take it out, the prosthesis?
When there is dusty glands, you have to take out the benign prosthesis and to remove all these necrosis or dusty areas.
As soon as possible? Or
as soon as possible. Because any delay, the necrosis will increase, will not decrease.
Dr. Rifai, one problem with this is sometimes you don't know if this ischemia is real or is it because of the mammy-rab dressing. So would you wait for some time or?
No, I mean, when it is a clear diagnosis, there is a dusty glands or there is like this black one. So in this case, we will go direct. But when we are doubtful, we are waiting also. We're still controlling the infection parameters, and also with daily control, it's okay. We are not in a hurry to remove that one.
Thank you, Dr.
Okay, thank you very much.
Okay, so we'll move to the next speaker, Professor Carol Batushi. He will tell us about the management of severe penile curvature and erectile dysfunction.
Use this one. Forward. Yeah, like this. So thank you very much, Mr. Chairman, and thank you everybody here. I really would like to start my lecture really thanking my really good friend, Osama. I do believe that Congress's scientific activity is not only science, it's not only sharing experience, but it's also growing up a friendship. And really, sometimes you get people that you really stick very much together, and you can have really fun wherever you are, even if you are smoking shisha or doing surgery, or just discussing about how to do things in his office and so on. So really, thank you very much and congratulations, Osama, for whatever you are doing, because I think this is the really very good results of a lot of work that is behind really this Congress. So
Having said that, we go in my talk, and I think this is the only talk on actually modern penal procedures on Peyronie's disease. And Peyronie's disease is a very well-known situation, as was said in the previous lecture. Sometimes people have a curvature of the penis, but they don't care because they're not affecting either erectile function or the curvature is impacting the possibility to have normal sexual activity. And so sometimes people do not know, and we need to find out. But it's not so uncommon having a curvature of the penis, and the reason is that it's about 15% of male people that may have these sort of problems. And the presentation is very simple because people feel some nodule in the penis, and they are scared because they believe in the beginning it can be a tumor. And so they go to the hospital, and then they start to discuss with us, and then they are reassured that it's just a benign situation. But some other times it's painful, and so when they have the erection, the pain is interfering with normal sexual activity. And so when we got this situation, even if we have erectile dysfunction, they come to us, and so we can treat these people. So as you can see, this is the way we have designed in Europe. This is the paradigm that we use. And when we have people with a curvature of the penis and erectile dysfunction, we go for, sorry, a little bit cold. We go for corporoplasty and penile prosthesis. So this is the way we can do. If we have a good erectile function, we can have two options. We can just do a very simple plication and straight the penis, or we can go for a graft that is the sorry, I think I do need to have some water. Sorry about that. I hope I will stay on my time. And but when we are in front of curvature and erectile dysfunction, then we have only one option, is to put the penile prosthesis and then to do eventually corporoplasty. So let's see how do we move, where we go for this. First of all, this is a paper that I published last year or 2 years ago. I'm sorry, I'm interfering in my lecture with this cough. This is what we were discussing in the previous session. It doesn't matter if you go through infrapubic, through penoscrotal, or through a subcoronal. I think the important is that you can manage nicely the procedure, and I think that the way you do is always the best way to do as far as you are confident of what you do. And so I think this is the message that is more or less shared all in the world. And the evidence of this meta-analysis was that there was no superiority of any of these approach with regards of the end results. And so basically there is no more complications, no more anything if you do one way or the other, but they are similar. And so you can achieve the best results whatever you do. But when you do the complex curvature, then you need more exposure most of the time. And in this situation, the important is to have enough space, enough visibility to play on the corpora. In the past, I was using a lot the double incision, so subcoronal, and the penoscrotal. Nowadays, I just do the subcoronal. It's very confident, very easy, and then you've got all the corpora in your hands, and so you can do very nicely the procedure. But it's also important to have those instruments to make the dilatation, because sometimes dilatation is really difficult, and so you need to have special instruments that you can see here. I like to mention my good friend from Cairo, Dr. Khbir, that he also designed an instrument, a cavernotomist, to help this kind of procedure, and so really I'm happy to remind also his instruments. And then it is important also to understand and to be able to face and to treat the possible complications. When you have When you have a severe fibrosis, then it's very easy. It's very easy to make perforation. Perforation may happen. It may happen on the top, may happen proximally, but they may happen. So what do we do when it happens? This is a simple video that shows you that when you try to go down and then it is difficult, you don't have the way to follow, and sometimes you perforate because the crura finish in this way, and so it's very easy that you go down and then basically you find that you have perforated proximally. Then there is a way, you can see here very nicely, one side has been perforated, so you need to use, usually we put the stitch through the rear tips to anchorate the side, the cylinders that has got the perforation. It's more problematic when you perforate distally, and especially when you go through the urethra. This happened again. I had 2 years ago one perforation through the urethra, and although I was very careful not to be there, but once I did a dilatation and I put the prosthesis in, then after a little bit I saw the prosthesis coming out. And so what you have to do, you can abandon the procedure, you can closure, so you need to isolate the urethra in double layer, you need to close the urethra nicely. If it's nice closed, then you can even complete your procedure, but you need to do a separate procedure. That means that you need to isolate the urethra and fix it. You need to isolate the corpora and fix it. Once both are fixed, then you can even continue. So this is not necessary to abandon the procedure. But if you don't feel comfortable, just abandon and then fix it and then come back no more than 3 months' time. It is important also the devices. We were discussing about the matter of infection. Now, there is no scientific evidence, no way, nowhere, that if you are quicker, you have less incidence of infection. But there is evidence that if you do the no-touch technique plus the device coverage of antibiotics, then you can have a reduction of infection. This is science, and so we need to be careful because something we can do can really reduce the time and the percentage of infection. So all the companies provide good devices that they have already, like Boston coated of antibiotics, or you can impregnate it of antibiotics, but both of them are good. And then finally, that's what we do when we go for a curvature. When is a mild curvature, then first of all, remember that everything is less than 30 degrees is considered normal. Normal means that it's a banana shape. It's not something we need to treat necessarily. So this is something the patient should know in the consultation. But if you have a 60-degree curvature, then you can play with this maneuver. It is very simple, and then you can retrieve a good, let's say, acceptable curvature, and the patient will be happy. But if it's more than the 60 degree, then sometimes, or if you have a calcific plaque, and then you need to remove it, then you may face some big defect. So in the past, we were discussing this way. So if it's a large defect, you need to cover. If it's less than 2 centimeters, you can leave it open. And this is some picture from Professor Austoni that we're using this, multiple incision and Montorsi. But I love this technique that I'm doing every time, and I do believe Paulo Egidio from Brazil is really one genius in this field, and so I consider him one of the best surgeons doing Peyronie's disease. And I hope, 5 minutes, so I can show you this 2 minutes operation. This was a severe curvature, so my initial approach, as you can see, is to try to have the neurovascular bundle because it was a dorsal curvature. So I just isolated the neurovascular bundle dorsally, and then this is the curvature. It was still 80 degrees. So at this time, I knew that I was going to have an implant of a prosthesis, and the corporoplasty. So I did the implant. You can see I was using the Rossello, and you can see all this material coming out when you scratch the tissue inside. We were discussing before with the other session that you can use the scissors, you can use the Rossello, but you need to destroy a little bit of this fibrotic tissue, but then it's still curved. So because you still have a big curvature, I don't feel to go and crack the penis, but I start to make, can you see, it's still 70, 80 degrees. So I decided to do this multiple incision. The multiple incision is really very easy and simple to do. You take your diathermy, you start to make these small incisions, you can reach even the cylinders. And once you finish, then you can see if there is still a little bit of curvature, then you can do a little bit of scratch. And then if you see the end results after you do this, the penis is straight. And when you have the end results and the penis is straight, then you just close the neurovascular bundle and you complete the procedure. In this case, there was a retropubic insertion of the reservoir and then you put the pump in the scrotum, you do the connections, and the end result is the penis is straight and then everything is done properly. This is the last slide that I want to show you. Basically, this is a nice systematic review of penile lengthening procedure with penile prosthesis. And as you can see, all these techniques may able really to achieve a good length, so an adjunction of length. And this is important for people who are complaining for shortening of the penis doing the procedure. There is a limitation that there are only observational studies, and there are no RCTs, and the high surgical skill is required to do this surgery. But this is normal. I agree that you need to be able to do penile surgery. Penile surgery is not only penile prosthesis. Just to tell you, if you do penile cancer, if you do peronis, all of these procedure on the penis give you confidence, and then it's easy for you, if you do urethra, and then it's easy for you to come back and do nicely and become a high volume center for this kind of surgery. So I really thank you again, the people inviting me here, and I'm quite happy to answer any questions on this topic. Thank you.
Thank you, Professor. Any questions?
Thank you for a very illustrative presentation here. I try to be very short. I know your throat. My questions in these lectures, what about the releasing incision with diathermy? You make a partial incision, not complete. If we go remodeling and then the corpora is opened.
Well, you need as much as is necessary to straighten the penis. You can do also all the shaft. It depends how much is the curvature, and then if you still need a little bit of scratch, you can do it. If you broke and then you have a little bit of
defect,
doesn't matter. If you make a gap that is huge, then it matters. But the reason you do this multiple incision is because you want to avoid to have a large defect, and it doesn't happen.
Okay. The second question, do you think this shock waves is effective in the Peyronie's disease if the patient has a good erection?
Sorry, I didn't understand the question.
Do you think this is a shock wave for
shock wave?
Yes,
Sorry, yeah.
for Peyronie's disease?
Yeah. Shock wave has been demonstrated on the guidelines. Shock wave is useful only for the pain. It's the only reason why when we can use in Peyronie's disease or if they have arterial insufficiency. So that are the two options. But it's not going to straighten the penis, it's not going to broke the plaque, it's not going to do any different stuff rather than solve the pain and eventually increase the penile arterial flow.
Okay. Dr. Carol, thank you very much. My question, if you have a big defect after the incision, would you use TassOShield as a graft? And what is your comment about TassOShield?
Well, when is a big if it's a calcific plaque, I remove it. Then it's different. I can't do this. I need to remove it and put a big patch. I don't use the Tacosil for that because although there is very good evidence by Atzikrisudolu and others that it's enough to protect the prosthesis, but in my mind, I still feel a little bit, let's say, uncertain that can flop out from the big gap, the prosthesis. And so I prefer to put, usually use any patch you use for peronis is okay. It depends where you live, because in all countries we have different patches, and this is one that is usually the myocardium is quite good. But I use that, and I prefer that. Tacosil I use sometimes when I do multiple incision. I do not have the dartos to cover, then I put the tacosil. But with a small incision, big gap, you can use tacosil by literature, but I do not use it. That's my personal experience.
Thank you.
Thank you for this
Thank
nice
you very much.
presentation.
Sorry again for my bad presentation in terms of coughing. I apologize.
No. Thank you. Now we conclude these sessions and inviting the next chairpersons for coming to the stage. Thank you.
And now, let us move to our next session, Egyptian Urological Guidelines Updates and Clinical Implementation. Please help me welcome the chairpersons on stage. Professor Dr. Ahmed Al-Ghayati, Professor Dr. Amr Gafar, Professor Dr. Hassan Gaid, Professor Dr. Wael Al-Gazayirli.
evening. So let's start. First speaker, Professor Dr. Salah Nagdab. He will talk about the Egyptian urology guidelines on cryptorchidism.
First of all, I'd like to thank the organizing committee for this opportunity to deliver this lecture about the guidelines of cryptorchidism, which I was honored to be part of this committee in Egypt. We have to know that the key benefits or aims of guidelines is to provide a standardized medical practice and enhance the safety by reducing inappropriate services and support the education and training and informed patient decisions and promote the cost-effective care without compromising quality. And we have to revise the level of evidence into level 1, which is the systematic reviews of randomized control studies, and reaching level 5, which is the expert opinion. The dilemma of Egypt is that the health services is not equal along the country. And here, one of our published articles, we showed that in Egypt, there is a delay at the age presentation of ORQBC in the undescent testis, and age presentation was significantly higher in patients from rural areas than those who were referred by a neonatologist. So we have a compound dilemma for the undescent tests in Egypt. We have no available neonatologists in every healthcare center. The rural areas are deprived of the medical services. For the guidelines, the case of bilateral cryptorchidism or there is associated hypospadias, we should provide a pediatric endocrinologist consultation. We have to rule out disorder of sexual differentiation and life-threatening condition like congenital adrenal hyperplasia, which is an emergency condition which should be discovered just after birth. For imaging study, the imaging in undescent testes has very little important rule. So the ultrasound is important only to rule out DSD or other upper urinary tract anomalies. Although MRI has reported to have a high sensitivity in diagnosis, but it requires anesthesia, expensive, and do not have 100% chance of success to find the testes. This is one of our articles. We showed that the diffusion weight image MRI may enhance diagnosis, but to say that the laparoscopy is the best in diagnosis of the undescended testes. For hormonal treatment, there is no agreement on the treatment of hormonal therapy in undescended testes, and the durable response is 6 to 12% only in undescended testes, even in bilateral cases. We have published this article about the hypovirilization and the undescended testes, and we think that in the future there may be a benefit of hormonal therapy in cases of severe hypovirilization and cases which have a short anogenital distance, as we have shown in the International Urology and Nephrology Journal. The keystone of undescended testes is to perform orchiopexy to preserve fertility, to prevent testicular torsion, to prevent malignant potential, and correction of associated hernia with the association of psychological effect. For orchiopexy, we have to know that if the testis is palpable or not palpable, not by ultrasound, not by MRI, only by examination under general anesthesia. If the testis is palpable, it is recommended in the Egyptian guidelines to perform whatever the single incision or the 2 incisions, whatever your experience is. For non-palpable testes, you had to go forward to laparoscopy. And if you perform laparoscopy, you may find one of the following. You may find the vase and vessel passing the internal ring, so you have to do exploration, inguinal exploration. The testis is present in the abdominal cavity. You have many options according to the length of the vase and vessel. If the testis has a short vase and vessel, you may perform a staged traction procedure or staged inguinal procedure, or even Fowler-Stephens procedure. For small atrophic testes, orchiectomy is advised. For vanished testes, nothing more is done after laparoscopy. And orchiectomy is advised in short vessel with a 12 years old boy with a contralateral normal testis. This is a video. This is the first stroker. In children, we do not perform varus needle insufflation. We perform the open technique, and this is Ala el-Ghanimi technique from Paris. The idea of this technique is just incision of the obliterated umbilical cord, and you'll find yourself inside the peritoneal cavity. It takes only 1 to 2 minutes to put your first stroker, and is easy one. The other 2 strokers are at the same level, at the umbilical level. The first thing is to have a normal testis. There is a normal vase with vasal vessels, and the vessel, as you have seen the cremastic vessel, the testicular vessels are evident. So if you have this view, you have to do an open inguinal exploration for the testis. This is a case of a blind-ended vase. If you find a blind-ended vase, this does not mean you have to abort the procedure, because you have to look for the testis. Even you may find testis near the kidney in its way of descent. This is another case of vanished testis. There was a history of testis which was present after birth, and later there was no testis. The atrophic testis, you find the vase with its vessels are atrophied, and even the inguinal ring is closed. If you find this photo, you have to abort your procedure. And how to perform orchiectomy? If the testis reaching the contralateral side of the inguinal ring, you can perform 1-stage orchiectomy. If not, you will perform a staged orchiectomy. And you have to expect that complication could occur, including testicular failure, in 3 to 4% of the cases after successful orchiectomy. And orchiectomy is considered according to guidelines, in atrophic testis, testicular tumor, or children more than 12 years with a contralateral testis normal. And orchiectomy of contralateral testis may be considered in atrophic or vanished testis with contralateral retractile testis. History of torsion, detorsion of a contralateral testis or retractile testis, contralateral testicular ascent. Early orchiectomy before 6 months of age is indicated of early torsion or congenital hernia, especially congenital hernia, because if you perform hernia without orchiectomy, the second stage will be difficult. In retractile testis, hormonal therapy is condemned. It is not allowed to give hormonal therapy for retractile testis. And orchiectomy in retractile testis is indicated only for decreased testicular size with follow-up. We perform yearly ultrasound and measure the testicular size. If there is a decrease in testicular size with follow-up, you have to perform orchiectomy. If associated hernia with the retractile testis, you have to perform orchiectomy. If the contralateral testis is vanished or atrophic, you have to perform orchiectomy. If there is a history of testicular torsion or suggestion of testicular torsion, the child comes to you with inguinal pain or testicular pain, which comes and go. You have to perform also orchiectomy. We have to revise again the Egyptian guidelines recommendations for the undescent testis. In refractory testis, at least till puberty, annual follow-up is advised for position and size of testis, and especially the size of testis. Perform orchiopexy for undescent testis at the age of 6 months and before 1.5 years. Evaluate neonate with bilateral testis for disorder of sexual differentiation. Child care provider should refer children to surgeon before the age of 6 months. Laparoscopic exploration should be performed for non-palpable testis under general anesthesia. Offer endocrine treatment for bilateral undescent testis, and thank you.
Thank you, Dr. Salah. Thank you. Any questions from the floor? Okay, thank you.
Next speaker, Professor Ahmed Elad. We are happy to have an up-to-date Egyptian guidelines. Thank you, our professor, to leading this program and the Egyptian Association of Urology.
Assalamu alaikum. Today I will present the guidelines about the erectile dysfunctions, the Egyptian guidelines. My name is Ahmed Ladl, Professor of Urology from Banha University. I'm appreciating this committee, chairman and dear colleagues. We will present today the Egyptian Urology Guideline on erectile dysfunction and focusing on how we adopted the international standards to our local Egyptian context. First, I would like to acknowledge the Egyptian Urological Association as well as all colleagues who contributed to the development and review of these guidelines. The objective of these guidelines is to present a contemporary evidence for medical practice in Egypt for the diagnosis and treatment of male sexual dysfunction. By the end of the objectives of this presentation is to understand the burden and the specific regional and challenges of erectile dysfunction in Egypt and the Middle East, to outline the recommended diagnostic evaluations and the key clinical questions, to summarize a stepwise treatment, including first and second lines of treatment and when to consider surgery. Erectile dysfunction is defined as a persistent inability to attain or maintain an erection sufficient for satisfactory sexual performance. Globally, erectile dysfunction affects more than 300 million men all over the world, and usually compounded by cardiovascular risk factors and metabolic diseases. In Egypt and the Middle East, the erectile dysfunction and premature ejaculation are the most common sexual presentation or sexual dysfunction presentations in Egypt and the Middle East. In one study, more than men, 90% of men presented with sexual dysfunctions have an issue about the erectile dysfunction. The socio-cultural stigma in our society makes the treatment delaying or treatment seeking to be delayed. And often with delayment, most patients have cardiometabolic diseases or comorbidities as diabetes and the cardiovascular system diseases that complicate the treatment. The Egyptian guidelines integrate the international standards with local realities, emphasizing a comprehensive assessment rather than purely prescription-driven management and evidence-based care. Equally important, the guidelines stresses on the patient education and shared decision-making to reduce stigma and improve sexual health outcomes. Overall, the Egyptian guidelines on erectile dysfunction aim to optimize the diagnosis, management, patient outcomes through a structured, stepwise pathway that starts from risk factor control and ends with advanced surgical options when needed, as we see in the previous lectures about surgery or the process of surgery in the treatment of erectile dysfunction. Diagnostic evaluation of the erectile dysfunction when assessing a patient with erectile dysfunction, the guidelines highlights 3 key questions in the evaluation process. First question is the ED predominantly organic or psychogenic? Second, what is the severity and potentially reversible component of the condition? The third question, what are the expectations of the patient and his partner? Answering these questions helps you to tailor your investigations and tailor treatment. If the patient is needing only lifestyle modification or needing some medications or combination of both. So, and the guidelines strongly recommended that in the diagnostic evaluations to start with a thorough and detailed medical and sexual history for all patients. We have to ask about the onset, duration, severity, and circumstances of the ED, associated ejaculatory or libido problems, and partner issues. In this context, it's important to involve the partner in this situation because the partner, as we said, it is half of the society, but actually she is 3/4 of the bed, so must be involved in the process of obtaining the history. So the guidelines usually also strongly recommended to obtain a questionnaire, mostly in the Arabic version if available, and this questionnaire helps you to optimize treatment and to optimize outcome and measuring or quantifying the outcome, so it will help in monitoring the cases all over the process of management. The guidelines also strongly recommended to perform focused physical examination. And you have to examine all the systems, cardiovascular system, endocrine system, genitourinary system, searching for any symptoms or signs of hypogonadism, a vascular disease underlying the condition, or Peyronie disease. So focused physical examination is strongly recommended in the diagnostic evaluation of these patients. Baseline laboratory investigations include fasting glucose, hemoglobin A1C, lipid profile, total early morning total testosterone in the initial workup of patients with erectile dysfunction. The guidelines strongly recommended to consider specific diagnostic tests when indicated. The indications of specific diagnostic tests are primary ED, young patients with pelvic trauma or who need revascularization surgery, patients with benign deformity, Peyronie disease or congenital curvature, patients with complex psychiatric or endocrine conditions, all at the request of the patient or his partner may need erectile function or specialized function test for medico-legal reasons for the insertion of PPI and to document end-stage erectile dysfunction. And sometimes for sexual abuse, maybe erection test is needed or specialized test may be needed. The specialized tests include intracavernous injection with duplex Doppler ultrasonography, and this is detected in young patients with the suspicion of vasculogenic erectile dysfunction. Nocturnal benign tumescence and rigidity tests may be needed in some unclear cases. Arteriography and dynamic infusion cavernometry and cavernosography are indicated in cases candidate for vascular reconstructive surgery. This is the diagnostic process, and these are the specialized diagnostic tests. So in the diagnostic workup, the algorithm is to determine the cause, number one. Number two, assess the severity of the condition and reversibility of any associated comorbidities, define couples goals, and tailor the management according to the patient's goals. So in the treatment guidelines stated that erectile dysfunction is treatable but not curable. Curable only except in some cases such as pure psychogenic erectile dysfunction or post-traumatic cases where lesions amenable to repair and correctable hormonal causes. Treatment principles and management must therefore address both underlying risk factors and the erection problem itself. What are the risk factors? What is the erection problem itself, and to investigate. Underlying clinical tissues, underlying medical issues, and involving the partner in your assessment in the diagnostic process, and then start with lifestyle modifications. Lifestyle modification is the foundation. Weight reduction, smoking cessation, physical activity, exercise, the optimization of diabetes and hypertension and dyslipidemia are strongly encouraged in all patients. Then start a therapeutic strategy, adopting a tailored approach based on the etiology and the patient preference. So the guidelines strongly recommend lifestyle modifications, use phosphodiesterase type 5 inhibitors as the first line, do early rehabilitation after radical prostatectomy using PDE5 inhibitors and vacuum erection devices. In cases with hypogonadism associated high erectile dysfunction, the phosphodiesterase type 5 inhibitors may be used in combination with testosterone replacement therapy. So the first line are still the guidelines, still first line pharmacotherapy remains the oral phosphodiesterase type 5 inhibitors, sildenafil, tadalafil, vardenafil, and avanafil. These drugs are highly effective and well tolerated in many patients, but the guidelines recommended to do dose titration for optimal efficacy, so making a balance between the side effects and the benefit of the medications. These are the phosphodiesterase type 5 inhibitors available in the Egyptian market and with different time of action, and the common side effects in all the class is headache, rhinitis, dyspepsia. For tadalafil, back pain and myalgia may be associated with the tadalafil. When patients are not responding to the first line, the second line treatment options were intracavernosous injection test and using albrostadil, prostaglandin in home therapy, intracavernosous injection home therapy. Have success rate of 85%, low priapism risk, and it's considered to be safe, but it has to be taught to the patients in the clinic for to decrease the side effects of pain and priapism or fibrosis. Vacuum erection device is effective in patients with multiple erectile dysfunction cases with multiple etiologies in 90%, but has high discontinuation rate and can be used after radical prostatectomy in the early rehabilitations. Hormonal therapy may be used testosterone for hypogonadism cases. Those are the strong recommendations of the guidelines. In some situations, there is a conditional recommendation. This is the PDE5 inhibitors failure, reassess the patients, reassess compliance. If the patient is have poor sexual stimulation or not considering the fat meals when taking the medication, you can use vacuum erection device conditionally in older patients with multiple comorbidities or requiring drug-free treatment. In some situations, home therapy with albrostadil is a best agent. after positive intracavernous injection test in the office. Shockwave lithotripsy, shockwave therapy is newly emerged line of treatment and has some efficacy in vasculogenic erectile dysfunction. Shockwave therapy and intracavernous injection of stem cell therapy, platelet-rich plasma, or Botox are emerging in the investigation regenerative and new strategies for the treatment. Shockwave therapy has a modest improvement in vasculogenic erectile dysfunction. Platelet-rich plasma is a promising but still investigational, and in botulinum toxins is investigational for cases of non-responders to the previous treatment, and you can interchange between these lines of treatment and see the patient expectation and assess the outcome after this. When to consider surgery for cases with erectile dysfunction? The guidelines have strong recommendations to keep the surgical options for the patient who failed less invasive therapy. Benign prosthesis is the strongest recommendation. Arterial vascularization in some cases. Venous ligation is no longer recommended. The key message from the guidelines: think of ED as a marker of general health, especially cardiovascular factors. Use a structured assessment and clear questions. Start with lifestyle modifications and stepwise, escalate stepwise for the patient, and then you can have an outcome satisfying the patient and his partner. Thank you for your attention.
شكرا جزيلا دكتور أحمد. شكرا جزيلا. في أي أسئلة من الحضور للدكتور أحمد؟ ممكن أسأل حضرتك سؤال؟
اتفضل.
كأنا أوبستريشن أند جاينيكولوجيست يعني. امتى اقدر اتعامل مع زوج الحاله لو جالي وادي له علاج، ولا لازم احول على طول لليورولوجيست والاندرولوجيست؟ يعني امتى اقدر اشخص زوج الحاله لو اشتكى عندي انه اريكتايل ديسفانكشن؟ هل نقدر نتعامل معاه كاوبستريشن ولا لازم نحوله على طول؟ لان احنا بنتسال السؤال ده في العياده دايما.
كأوبستريشن حضرتك بتسأله في العيادة لأن
يعني زوج الحالة بيسألني.
You have to some idea about what questions you will do with these patients.
أيوة.
So it's better to start with a validated questionnaire. يعني بناخد questionnaire ونشوف severity of the condition. If the condition is mild or mild to moderate, you can start with first line medication as phosphodiesterase. The phosphodiesterase that give some efficacy with a long-term or short low dose is tadalafil.
تمام، اوكي مظبوط.
Sildenafil can be taken on demand from 25 milligrams up to 100 milligrams on demand.
Okay.
So you can start with first line therapy with phosphodiesterase type 5 inhibitors. If he is not responding, okay, don't bother yourself and
يبقى لازم
send him
نريفير
for
لحضرتك.
andrologist.
اوكي شكرا لحضرتك. احنا
Thank you,
بنسال
sir.
السؤال ده على طول، فعشان كده بس قلت استفيد من حضرتك.
لا تحت امرك.
شكرا
حضرتك
جزيلا.
start with him and he is no response. خلاص send for one who have space in his mind to accommodate this patient.
اوكي شكرا لحضرتك. شكرا جزيلا. محاضرة جميلة. شكرا.
Thank you for attention.
شكرا. احنا بنشكر حضراتكم. احنا دكتور ماجد بس مش موجود، فاحنا نهينا كده السيشن. شكرا جزيلا ليكم.
And now we will move to our next session, Updates in May Urology. Please have me welcome the chairpersons on stage, Professor Dr. Ahmed Al-Baz, Professor Dr. Autuf Abu Zahwa, Professor Dr. Gamal Silmi, Professor Dr. Hafiz Mannaa, Professor Dr. Lu'ay Ayman, and Professor Dr. Lutfi Al-Bindari.
Bismillah ar-Rahman ar-Rahim. I would like to welcome you all for this afternoon session. Actually, we'll start with the first presentation, updates on endoscopic management of urethral stricture. Actually, we have Professor Yasser Farahat, is the chair of the Asian Urology Association, and meantime is the Secretary General of the Arab Association of Urology and United Arab Emirates. Welcome, Professor Yasser.
Thank you and good afternoon. Thank you for introduction. Actually, as long as introducing me as currently President-elect of SIU and Executive Director of the Arab Association and past President of the Asian, but I am still proud to be a Professor of Urology from Tanta University, where I was graduated and educated and still affiliated. This is my brightness, although I am working now in Dubai for the last 15 years. I'll take the opportunity just to remind, to mark your calendar with the upcoming interesting events. We have the Arab Association Annual Conference that will be in Jeddah next November. And also we have in Abu Dhabi, in United Arab Emirates, the annual conference of SIU, and will be joined with the Emirates Surgical Society. So you are welcome to participate in both. My talk today is about the stricture urethra. We know it's a very common pathology that we are facing in our routine daily practice as urologists, and the focus is about the endoscopic management. Regardless to the type or the severity of the stricture of the urethra or the location, either anterior or posterior, if we look deeply into the options of treatment, we are limited to only two options, either endoscopic or it can be urethroplasty by surgery. And the endoscopic can be by visual internal ureterotomy or dilatation or laser or whatever, but it's all under the category of endolumen. If we look to the outcomes of both, especially for endoscopic or endoluminal, we can find that stricture-free rate is very low, and it can be only 8% in a median of less than 1 year. And most recurrence occur in the first post-operative year. And we can see also patients without recurrence were only those with a stricture short in length, which is limited to 1 centimeter or less. So these are the facts of the outcomes of the endoluminal treatment. Actually, this is because when we evaluate by ureterogram, we sometimes misdiagnose the extension of spongiofibrosis, which can be detected by sonoureterogram, which is mainly the underlying pathology of recurrence and leading to failure rate. So looking to our practice, although these facts, we know that the outcome of endoscopic treatment of stricture urethra are less, but still we are doing visual internal ureterotomy more frequent, even in recurrent cases. And we understand that the patient will come back more and more and come back again with recurrent of stricture urethra. And this has been proved by a survey done by the AUA that trying to explore the surgeon bias. As endourologists, sometimes you are biased to what you are doing, what you are expert in. So we found that 1/3 of surgeons participated in this survey are still doing internal ureterotomy in spite of clear information that the recurrence rate is very high, especially in recurrent cases. So we should evaluate our real practice and how affecting the outcome of the patient. So again, we are between two options, the endoscopic or visual internal ureterotomy, which is frequently done by most of us, although it has a low outcome. And the other option, which is urethroplasty with less practice, but should have a better outcome. So we have a gap. For many years, we don't have something in between to get the outcome, high outcome, and to be minimally invasive. And here is the concept of what's called the endoscopic urethroplasty, trying to apply the concept of urethroplasty in a minimally invasive procedure instead of having a surgery. A lot of trials has been done using skin graft, using buccal mucosa, using different materials, but the challenge is how to fix these grafts endoscopically, and I will share with you here the study that we had in Tanta University many years ago and published in the Journal of Endourology. We're using a small intestinal submucosa graft, which is considered acting like a scaffold to help generation of a new endothelium. But again, the challenge is how to fix this graft at the site of the structure, which is really not easy. We fixed it on the balloon of Foley catheter and trying to put under vision with the endoscopy at the site of structure, but there is no guarantee that it will be stabilized at the same position for a couple of days, still having the same efficacy. So again, the endoscopic urethroplasty theoretically should have a good concept that getting the outcome of urethroplasty endoscopically and replacing the spongiofibrosis with a healthy tissue. But the challenge is it's a difficult fixation, as we mentioned, missing long-term follow-up in most of the study has been done, and it's individualized from single-center studies and the lack of strong evidence behind that. Recently, in the last few years, we received from the guidelines and from the market what's called the drug-coated balloon paclitaxel. And it has been proven that it will work effectively, especially in those patients with recurrent stricture urethra and longer stricture urethra up to 3 centimeters. Why paclitaxel? It's a known medication that's used as in cancer treatment, but it has anti-proliferative medication and inhibit the mitosis and prevent cell division and decrease the cell growth and inducing more fibrosis. So it can help in reducing the obstruction. So it's simply that you have a balloon and you can covered by this paclitaxel. Once you do internal ureterotomy or dilatation, putting the balloon at the site of the structure and keep it for 2 or 3 minutes, and then this material will be absorbed in the mucosa and reducing the fibrosis. Keep in mind that you have to get a full cover of the length of the structure because we are treating more than 1 centimeter up to 3 centimeters. So if you have 3 centimeters, ensure that you get the proper size, 5 centimeters to overcome the whole length of the urethra, of the structure. So how to apply it? It can be either under direct division, because this is the most challenging part, to put the balloon at the correct site, or can be by fluoroscopy guided. So either to mark the site of the structure by fluoroscopy and inserting the balloon at the site of the structure, or you can go under direct division and inserting the balloon alongside the scope, and you can ensure that it is in the proper position. Actually, you have some precautions because the challenge that we don't know how much of this material will be intact to the mucosa, so we're trying to minimize any maneuver to reduce the contact of paclitaxel to the site of the structure by avoiding to doing endoscopy or cystoscopy after you do the dilatation, or avoid to have inserting a Foley's catheter. Sometimes we do it without. So because all of these maneuver can minimize the amount or the dose of paclitaxel, which till now we don't know exactly what is the ideal dose. Looking to the outcomes of these new techniques, which we hopefully that can fill the gap between the endoscopic treatment, the common visual internal ureterotomy and urethroplasty, and we can see here improvement after 1 year follow-up of both clinical data from IPSS and also from Euroflow, which can improving the Qmax. Look here to 83%, but read it carefully. It is freedom from re-intervention rate. Sometimes when you read the publication, you have to read it carefully. Re-intervention rate, it doesn't mean exactly that the patient is returned to normal. He can be improved, he can still voiding nicely, but it may not be 100% cured. So 83 freedom from intervention rate. Again, after 3 years, it's 77% freedom from re-intervention rate, and still most of patients having a good response, a good outcome of both clinical and Euroflow data. So we consider this new technology last 5 years, and the data that we received from all literature and some cases that we have it in our hospitals, that paclitaxel balloon-coated urethral dilatation is a minimally invasive treatment. It took maybe 10 minutes to finish this procedure, and it can work for relatively long structure up to 3 centimeter, and we have in our hand, short and medium term, up to 3 years, a good outcome, relatively good outcome. But we should consider as well future long-term data still required. What will happen after 5 years? Still, we don't have these data. Refinement of the technique, that point that I mentioned, to ensure the proper position of the balloon at the site to be better to be under fluoroscopy or under direct vision by endoscopy or combination of both. This is one point. And also we need to standardize and to have an understanding how much or the dose of paclitaxel absorbed and how to maintain the maximum contact between the paclitaxel and the mucosa after internal thrombectomy. So I think we are expecting in the upcoming few years to get further data that can establish or supporting this technique or getting some more modification. I really thank you for your attention and welcome.
Well, thank you very much, Dr. Yasser. Any questions from the floor?
Thank you, Dr. Yasser, and I would like to thank Professor Osama Attas for the invitation for this highly organized conference. Dr. Yasser, I have one question for you. What is the catheter time after Optilum insertion? Catheter time.
The catheter
For how
time,
long?
usually we keep it similar as visual internal erythrotomy from 1 to 3 days, not more.
Is the degree of spongy fibrosis affect the outcome of Optilum?
Theoretically, for sure, yes, but you know that having the spongy fibrosis by soniourethrogram is not a common practice in all cases, so we don't have any study till now. Even in my hospital, we are not correlating the degree of spongy fibrosis with the success or failure rate of paclitaxel.
I think it is an important point to consider. Yes.
Yeah, but actually we depend on the length of the structure, and we committed to not exceeding 3 centimeter length. The shorter, the better the outcome, that we can confirm that.
Could it be repeated, Dr. Yasser?
It's a good question. No data till now for repeated after recurrence, after using paclitaxel, not reported yet. But theoretically, yes, you can repeat. But no strong data supporting that.
Yes, thanks.
You tried for all the type of the structure, I mean, post-gonococcal, post-inflammatory, post-traumatic, or you just choose it in the post?
Regardless to the etiology.
You tried in all?
Yes, in all cases.
We have the same results?
Yes.
Dr. Yasser, thank you for the elegant lecture. I would like to ask you about paclitaxel, how it is fixed in the urethra after you remove the catheter.
Actually, the balloon, you will inflate the balloon, as you can see in the video, and for 2 or 3 minutes, and then deflate the balloon and remove the balloon. That's it.
It's fixed already.
It's not a fixed. It's just we'll keep it for 2 or 3 minutes, either controlled by fluoroscopy, or it can go beside the scope and you can inflate it under vision.
But if you are not fixing anything in the urethra, this is just like dilatation effect.
No, you have two techniques. You have two schools. One, you do internal erythrotomy to induce cracking or raw area of the mucosa, and then you put the balloon with paclitaxel to ensure good attendance. The other technique that you can go with a balloon without paclitaxel, and you do the cracking and then putting the paclitaxel to be absorbed in the tissue. So this is the concept that you need to ensure that the material will go deeply in the spongy fibrotic tissue and to reduce the mitotic figures and inhibit the fibrosis. How to be maintained for how long? We avoid any vigorous maneuver like doing complete cystoscopy or putting a large catheter. Sometimes in short urethra, we keep it without catheter, even and patient discharged at the same day, but usually we keep it
مفيش ابتيك في البروستات ولا طبعا في اي حته ثانيه. دول الحالتين اللي هم عندهم لوكالي ادفانسد بروستات كانسر عالجناهم بالسايبر نايف. وانا بزعم ان انا عندي اكبر مجموعه للعيانين اللي خدوا السايبر نايف على لوكالايزد او لوكالي ادفانسد بروستات كانسر، وذا بيست فولو اب ليهم على مدار 4 سنين. العيانين البي اس بتاعهم لسه ما وصلش 1/10. البرزنتيشنز اللي بعد كده هتبقى على الميتاستاتيك هرمون سنسيتيف بروستيت كانسر والريسبونس للنيو هرمونال ايجنتس، الادويه اللي بيسموها الانزالوتامايد، الابيراترون اسيتيت، الابالوتامايد والدارلوتامايد. من المعدل اللي بيقل بيه البي اس اي ده بعتبره احسن بروجنوستيك فاكتور in response to new hormonal agents. كل ما يكون المعدل البي اس اي بيقل بسرعه وبينزل لمستويات ال1/10 و2/10، كل ما بمتوقع انه مش هيحتاج حاجه على النيو هرمونال ايجنتس. عشان لما نسمع كلمه دوبلت وتريبلت اللي زمايلنا في الانكولوجي بيستعملوها نبقى فاهمين احنا هو مش محتاج هنا تريبلت، مش محتاج دوسيتاكسول ولا كابازيتاكسول ولا التاكسنس كيموثيرابي. بينت كمان انها متابعه العيانين لمده 5 سنين ان ده كان very good prognostic factor in initiation of the new hormonal treatment as a doublet therapy. الستاديز published ومنشوره سواء جايه من مايو كلينيك ولا جايه من حاجات في نفس المستوى بتاكد ان الهازارد ريشيو للناس اللي بتحب الحسابات وكده هوت. الهازارد ريشيو ديت اكتر حاجه بيستعملوها دلوقتي بتوع الاحصاء زمايلنا. زي ما بنيامين ديزرائيلي قال سنه 1830 there are 3 lies. simple lies زي الواحد لما بيكذب على مراته كده، damn lies كده ملعونه، واللي أسوأ منهم الستاتستكس. بس الهازارد ريشيو تقول لا هي مش دام لايز، بالذات لما يكون البوبيوليشن كتيره او بتعديها على كلينيكال ستاديز كنترولد راندومايزد ستاديز بتشوف الهازارد ريشيو 1 يعني الدواء او العلاج او الجراحه ما جابتش نتيجه. اقل من 1 يعني مثلا 7/10 هازارد ريشيو دي معناها ان جابت نتيجه as compared للكنترول ستادي. لو 1/1 أو 1/2 يبقى معناها إن الدواء أو الجراحة أو العلاج كان أسوأ من الكنترول ستادي. فأنتوا هتلاقوا هنا في كل الكلينيكال ترايلز ديت كلها في ناحية الأقل من 1 في 5/10 و6/10. ده العيانين بتوعي انا التانيين، ما بتكلمش بقى على مايو كلينيك دلوقتي، بنتكلم على التشيلدرن كانسر هوسبيتال 57 ان هو عيان بيبقى جايب البي اس اي بتاعه 280، عنده مالتيبل ليمف نودز، عنده سنجل بون ميتاستاسيس، ودول بنسميهم ميتاستاتيك هرمون سنسيتيف او كاستريت سنسيتيف بروستيت كانسر. ولما بنديهم الاندروجين ديبريفيشن ثيرابي لوحديه ما بيكفيش، ده طبقا للجايد لاينز بتاعت الاي او اي وبتاعت الاسكو وبتاعت الازمو والأوروبيين المساويه ليهم. وبنتابعه بالبزمه، بنتابعه لمده 6 شهور، بنتابعه لمده سنه، بنتابعه لمده 18 شهر، 24 شهر، وبنشوف الفرق الكبير قوي ما بين البي اس ام اي اكسكريشن في البروستات بيد وفي الليمف نودز. بتشوف الحجم الليمف نودز كانت قد ايه وازاي اختفت ومبقاش فيها اكتيفيتي. والعيان دلوقتي البي اس اي بتاعه اقل من 1/10 بمجرد ما احنا استعملنا الاندروجين ديبريفيشن ثيرابي بلس نيو هرمونال ايجنت، ما احتاجش كيماوي والفولو اب بتاعه ماشي كويس. ده عيان تاني جاي من الصومال الشقيق، مش من ارض الصومال اللي مش شقيق. الاس يو في بتاعه في الليمف نودز وفي البون ميتاستاسيس في حدود ال50 وال60. عامل البزمه ديت في مستشفى مش مصري، وان كان اللي بيشرف عليها مصريين، ومطلعين ان هو مالتيبل هاي ريسك هاي فوليوم ميتاستاسيس اوف بروستيت كانسر. ده بعد العلاج بتاعه حتى البلمونري نديولز اللي هي في بتعتبر ميتاستاتيك M1C يعني مور ادفانسد عن ال M1B اللي هي بون ميتاستاسيس، favorable response. ده البون metastasis مكتوب في البريفيوس ستادي على الناحيه الشمال multiple super duper بازما بيت سي تي عنده حوالي 45 بون ليجن بالاضافه الى فيسرال والبلمونري اللي انا كنت قلت عليهم ودوت في الفولو اب بتاعه فرق كبير قوي ما بين البريفيوس ستادي وتودايز ستادي. انا ما كنتش بستعمل الكلام ده من مخي، انا ماشي على الجايد لاينز بتاعت الاي او اي زي ما اتفقنا، اليوروبيان والايكويفالنت ليهم كده هوت. هم قالوا ان في عيانين هيحتاجوا الميتاستاسيس دايركتد ثيرابي، يعني هنستعمل السايبر نايف او راديو ثيرابي نتارجت السايت اوف ميتاستاسيس عشان العيانين ما يتحولوش الى كاستريت ريزيستنت ونضطر نديهم الجين ثيرابي الجديد اللي هقوله في اخر البرزنتيشن بتاعتي. الاستادي ديت طبعا واحده من اشهر الاستاديز على مستوى العالم. فريدي سعد والكووركرز بتاعه الدكتور تميم نيازي ناشرين الكلام دوت في سبتمبر 25 قبل ما انا ابتدي العيانين بتوعنا هنا في 57 ب3 سنين. بس هم بياكدوا ان الستيريوتاكتيك بودي راديو ثيرابي او السايبر نايف لما تارجت بيها الميتاستاسيس العيان would have the best chance of response، سواء هو كان هرمون ريزيستنت او كاستريت ريزيستنت يعني كده. ما كانش بس فريدي سعد والمجموعه اللي في كندا. بالمناسبه فريدي سعد هو يورولوجيست بالمناسبه عشان يعني الناس تبقى عارفه ان هي الحكايه هو مش انكولوجيست ولا راديشن انكولوجيست يعني. مجموعه ثانيه ناشرين قبليها بسنه الستيريوتاكتيك تايلين زي ما اتفقنا، دي الكلمه العلميه الاصح للسايبر نايف يعني كده هو للعيانين اللي عندهم كاستريت ريزيستنت بروستيت كانسر، ازاي بيستفيدوا منها لما بتارجتها مع النيو هرمونال ايجنت كده. برضو قبل ما يتنشر الكلام دوت المالتي سنتر ستاديز دوت اللي بيقول انت بتحتاج تقيس الاس يو في المين ابتيك اوف ذا بزما in the body وتديله مين اس يو في او اس يو في ماكس او تحدد التيومر فوليوم توتال تيومر فوليوم بيها. ده هيساعدك كبروجنوستيك فاكتور تاني. يعني البروجنوستيك فاكتور الاولاني اللي انا كنت بستعمله الريت اوف ديكريز ان بي اس اي ليفل، والحاجه الثانيه الريت اوف امبروفمنت في البزما اكتيفيتي. ومنشور الكلام وبين ان هو في عدد كبير من العيانين في اغلب العيانين اللي خدوا لوتيشيوم بلس ستاندرد اوف كير استفادوا كتير قوي. ان انت في الانيشال بازما بيت سي تي تبقى بتعرف تقرا البازما بيت سي تي وبتعرف تترجمه ان العيان ياخد تريتمنت اوبشن ايه. قالوا طبعا الانتربريتيشن البيز لاين بازما total tumor volume is prognostic for overall survival عشان ما تفاجئش بعد 3 سنين من العلاج ان هو كان الاختيار كان كويس ولا لا. And it's predictive for a beneficial يعني among all speakers يعني it's not nice to have the time out يعني. Okay. عيان تاني من العيانين اللي كان عندهم heavy bone metastasis و responded to treatment. I'm going to walk you through but interesting هنا ان العيان دوت كان عنده قبل العلاج كان عنده الفوليك اسيتر والبروستات بتاعته كانت حوالي 2 كيلو جرام، وان هو دلوقتي فري اوف كاسيتر والبون ميتاستاسيس كلها اختفت والاس يو في ماكس بتاعه 3.6. التلازوبريب which is PARP inhibitor ده النيو جيناتيك تريتمنت اللي هو بيسموه الجين اديتنج ثيرابي، بيستخدم للعيانين اللي عندهم HRR هيومن هومولوجس ريكومبيننت ريبير جين ثيرابي موجود في مصر واستعملته. بيفيد العيان بنسبه متوسط 10 شهور يحسن السرفايفل بتاعه. وان كانت في الاستادي ديت اللي نشرها كريم فزازي اشهر اونكولوجيست على وجه الارض، هو راجل ايراني ابوه وامه فرنسويه وبيتكلم انجليزي كويس، لكن في الاستادي ديت داخل معاه فيها حوالي 17 اسر. يعني مش كفايه انك بتشتغل في جوستاف روسي ولا في 57 ولا في معهد الكلى في المطريه، لا انت مدخل معاك 17 انستيتيوتس من اليابان ومن كوريا ومن امريكا ومن حتت تانية في اوروبا، عشان يثبت ان في غالبيه العيانين لما بيكونوا HRR deficient gene therapy، لما هياخدوا التلازوبريب او الاولابريب هيستفيدوا منهم. وفي الستادي ديت مبين السرفايفل ادفانتج 30 شهر. ده العيان بتاعي اللي انا كنت عامل له الاتش ار ار diagnostics من سنتين فاتوا. وقلنا بقى الامبورتنس اوف فوليوم ديزيز عشان الوقت، لكن لازم اليورولوجيست وهو بيعالج في اليورو انكولوجي يميز ما بين اللو فوليوم والهاي فوليوم، يميز ما بين الكايند اوف ميتاستاسيس از ات ليمف نودز ولا بون ولا فيسرال، ويعرف بيعالج بايه اكتر. دول عيانين بتوعنا ازاي كان عندهم locally advanced disease وبعدين الليمف نود ميتاستاسيس on both sides of the pelvis في البريفيوس ستادي واختفوا ازاي في التودay's ستادي. ده البون سباين بتاعه في حوالي 11 بون ميتاستاسيس، وفي الافتر تريتمنت ازاي يتحسن. ده حالة تانية من السوبر دوبر بون سكان معمولة هنا، الكلام دوت مش في أمريكا. تيك هوم مسجز عشان ما نضيعش وقتكم وعشان ما يقفلوش النور علينا تاني. نمرة واحد in multidisciplinary treatment works better with urologists of scientific background. أنا بعمل راديكال بروستاتكتومي من سنة 1992، لكن لما لقيت ان السايبر نايف موجودة في مصر أحسن وما بدخلش العيان مستشفى ولا بركب له قسطرة أسبوعين ولا بيعاني من انكونتيننس ولا بيعاني من امبوتنس، ابتديت اعرف مين العيانين اللي هيستفيدوا من السايبر نايف، وابتديت اعرف اناقش في الام دي تي او المالتي ديسيبلينري تيمز ان العيان دوت هنحتاج له لوكال ثيرابي ولا مور ادفانسد ثيرابي. Cyber knife or stereotactic body radiotherapy is a valid new option for localized prostate cancer with proven treatment response in terms of quality of life, radiological progression free survival والبي اس اي. وزي ما قلنا البي اس اي عندي في المجموعه بتاعتي العيانين بتوعي هو 0.03 لفولو اب 40 شهر. مش كده وبس، ده كمان الراديوثيرابي targeted metastasis would improve survival. حتى في العيانين الميتاستاتيك كاستريت ريزيستنت بروستيت كانسر، بدل ما اديله البالفيكتو، الحقنه موجوده في مصر هنا اهوت، الحقنه الواحده ب 250,000 جنيه والعيان بيحتاج له من 5 إلى 6. بنديله الستيريوتاكتيك او فوليومتريك موديوليشن ارك ثيرابي راديو ثيرابي تو سبورت الميتاستاسيس او تو امبروف الاوتكم بتاع الميتاستاسيس في الكاستريت ريزيستنت بروستيت كانسر. البازما is the best bioradiological evaluation. It's objective, it's digital, it's accurate to observe treatment response. آخر حاجة new hormonal agent is good. واحدة من أجمل الحاجات في حياتي كان هو طبعا الواحد كان بيشوف الدكتور غنيم أعظم اليورولوجيست في التاريخ المصري يعني، على الأقل عند الأوروبيين والغربيين. الواحد اتعلم من بدري منه إنه ممكن يبقى محلي وعالمي زيه كده هو في الطموح بتاعنا. أشكركم جميعا وجاهز لأي أسئلة.
دكتور عبد العزيز باشا for this highly informative lecture. I would like to ask you one question. What is the indication of could cyber knife replace conventional radiotherapy in the post-prostatectomy setting? I mean after radical prostatectomy when relapse occur, cyber knife could replace conventional radiotherapy?
أشكرك بيه. هو طبعا في الاستادي بتاعت نيازي اند فريدي سعد اللي منشوره في سبتمبر 25 في اللانست اونكولوجي بتقول ان هو Cyberknife, stereotactic body radiotherapy, is the best treatment for metastasis or local recurrence.
Local recurrence. Yes.
Or local recurrence. It's the advantage of cyberknife.
I mean, conventional radiotherapy is more better than cyberknife, or cyberknife equals the conventional radiotherapy.
Cyber is more accurate.
Yes.
And safer. So, simply, it's better. But if it's not available, then we move to the conformal radiotherapy.
Is it available in Egypt, Dr. Abdulaziz, cyberknife?
وتاني.
Where is it available in Egypt? Cyberknife is available in
Only
Egypt.
place in Africa is in 57 وهو ده السبب ان انا رحت 57 يعني ال MDT وهو الجهاز الوحيد اللي موجود في مصر و it is worth it وهو الجهاز الوحيد الموجود في افريقيا بالمناسبه يعني بس ما فيش حد تاني.
شكرا يا ريس. Any questions from the floor?
أنا عاوز أسأل دكتور عبد العزيز شكرا جزيلا على المحاضرة الجميلة دي. أنا بس كنت عاوز أسأل حضرتك على التست اوف تايم. يعني احنا بنتكلم هنا حضرتك على 3-4 سنين. You are telling us about survival of 3 years or follow up 3 years. In the conventional radiotherapy or surgery we are talking about 15 years survival. فايه اللونجست سيريز اتعملت على السايبر نايف؟
The longest series locally in Egypt, it's 4 years. And I have this worldwide in the US, it's 15 years.
Yes.
15 years.
And the 15-year survival is
It's
the same as surgery
as good as surgery in terms of efficacy.
As primary therapy.
And in terms of safety, it is better.
And you are talking
Quality of
about
life, I mean impotence and continence.
as primary therapy or as recurrence?
As a primary therapy.
Yes.
For the group from Karim Fazzazi, Gustave Rousset and co-workers that I showed there, that's for the castrate-resistant prostate cancer, this 36 months follow-up. يعني أقصد 36 3 سنين follow-up للcastrate-resistant prostate cancer.
تمام. Thank you very much. We'll move to the next presentation by Dr. Ahmed Al-Hussein, Mansoura University. He will talk about updates in BPH management, the new players.
Assalamu alaikum. Peace be upon you. Inshallah, I'm presenting briefly the updates in the management of BPH, the new players. I have nothing to disclose. I do believe the different modalities for treatment of BPH, the so-called BPH players, are just like our national Egyptian footballers. We have the old players like Hussam Hassan, the old new one like Mohamed Salah, and the newest one, Hamza Abdelkrim. The old players in BPH management, the cavitating procedures, the TURP, are of proven safety and efficacy with well-known untoward effects, well-established, like Hussam as a player, not as a coach. And the old new players like Mo represents in the field of BPH, the laser inoculation and vaporization. The concept remains the same, but the technology pushes forward. We had the diode, we had the green laser, we had the holmium laser with its modifications, the virtual basket, the magneto effect, and recently the TFL. And the newest players, the concern in our lecture today is the MIST, the minimally invasive surgical therapies. They have the good potential, they have the good capability, but questionable future like Hamza Abdelkrim. So the minimally invasive surgical therapies are so crucial because the patient's quality of life matters. These are outpatient procedures, which means reduced anesthetic risks. They provide faster recovery and preserve its sexuality in all aspects of sexuality, especially preservation of the antegrade ejaculation, and of course the theoretically lower healthcare costs. But the drawbacks are the size limits of the prostate, especially the presence of the median lobe and the lack of long-term data. The MES can be categorized into non-ablative procedures like the PUL, prostatic urethral lift, the prostate artery embolization, and the I-10, temporary implantable nitinol device. And we have the ablative procedures, whether thermal-based like the Resume or the echo laser, and we have water-based non-thermal, the aquablation, and recently the Optilium. Any prostate surgery to evaluate or critically appraise any prostate surgery, it must achieve the Ventafactor, the safety, the efficacy, the durability, the cost effectiveness, and accepted learning curve. And to apply this to MEST, let's put MEST into test compared to the standard. First of all, the PUL. In this unique study that included 80 patients with prostate size from 30 to 80, the PUL showed lower IPSS and Qmax improvement at 2 weeks and 3 months compared to the standard URP, higher retreatment rates reaching 13.6%, but preservation of antegrade ejaculation in 100% of cases versus 34% in the classic URP. And even in the presence of the median loop, this study demonstrated that in total number of 45 patients with obstructive median loop, still there's comparable improvement in the IBSS, Qmax, and the quality of life to those with lateral loop enlargement only. And that's why the AAU strongly recommend the PUL as an alternative line of treatment for BBH patients in the prostate size from 30 to 80, less than 70 milliliters, especially in patients willing or needing to preserve their sexuality. The second is the Resume, the convective water vapor therapy. It gained FDA approval in 2015. And in this unique study, the Resume 1 study, it included 196 patients categorized into 2 groups, 135 patients in the Resume group and 61 sham control. The Resume proved the improvement in the IBSS, the Qmax, by nearly 50%, with no reported erectile dysfunction or ejaculatory dysfunction, and retreatment rates 11%. And these are the recommendations. They are nearly the same as the prostatic urethral lift. The AUA considered the Resume system as alternative treatment option for LUTS due to PBH in patients who desire preservation of erectile and ejaculatory function. And the AAU recommends further randomized controlled trials in order to establish solid mid and long-term efficacy and safety of such technique. The third is the aquablation or the aquabeam, and we have the Water 1 trial and the Water 2 trial that compared the aquablation to the standard URP. And in both trials, there was significant improvement in all urinary outcomes, the IBSS, the Qmax, the BVR, and the quality of life, and no reported erectile dysfunction or ejaculatory dysfunction, with much less retreatment rates compared to the TURP. But the Water 2 trial expanded the size of the prostate. The Water 1 focused on the prostates from 30 to 80, while in the Water 2, the prostate size included was from 80 to 150 milliliters. There was improvement in the urinary outcomes, but reported ejaculatory dysfunction in up to 7% of cases. The safety of the aquablation is still a concern. The bleeding is the problem. The reported blood transfusion in Water 1 trial was 3.9%, increases to 10% in the Water 2, and the incidence increases as the prostate size increases. That's why this technique is not safe for patients on ongoing antibiotics or anticoagulants, and that's why in the AU recommendations, it is weakly recommended as alternative to TURP for patients with prostate size from 30 to 80, and it is strongly recommended to inform the patient about the high possibility of bleeding and the lack of the long-term outcome data. We have also the I-10, the temporary implantable nitinol device, where this device is placed for a week nearly in the prostate to induce pressure necrosis and ischemia of the prostatic tissue. And the outcomes are promising. There is just temporary dysuria, hematuria, urgency, and pelvic dysfunction, but significantly improved urinary outcomes for prostates from 25 to 75%, reaching 40% at 1 year, with no reported ejaculatory dysfunction. But the problem, there is limited randomized controlled trials evaluating the long-term data. Also, we have the transperineal laser ablation, what's called the echo laser, where ultrasound-guided transperineal diode laser ablation of the prostate is applied, creating what's called the coagulative necrosis. In this study that evaluated the echo laser, they reported the improved IBSS and Qmax with preservation of sexual dysfunction, but the data are heterogeneous. And that's why the NICE interventional procedure guidelines stated that the transperineal laser ablation can be used for loss due to BPH in patients who are not fit for the standard URB or other standard urethral procedures. And the guidance notes the uncertainties because most of the published studies have small size samples, short-term follow-up, and the need for further studies with longer-term data and to make sure what is the safety and efficacy of such procedure. And lastly, we have the Optilium, which is the drug-coated balloon. I think Dr. Yasser spoke about it in the urethral stricture. It is FDA approved for both urethral stricture and BBH with different design. That from the urethral structure has a certain design that differs from that for the BBH. It is coated by paclitaxel to induce both mechanical dilatation and delivery of the paclitaxel into the tissue as anti-proliferative medication that inhibit tissue regrowth. And we have two unique studies, the Pinnacle study and the Everest study. The Pinnacle study is a randomized controlled trial that compared the Optilium to the sham, and the Everest is a cohort study on 80 patients, and the results in both showed that the Optilium is effective. There is significant reduction in the IBSS, significant improvement in the Qmax, and there was significant improvement in quality of life and the overall urinary function for at least 2 years. And it is a safe procedure. There is only some reported mild to moderate transient untoward effects after the procedure, like hematuria, urinary tract infection, dysuria, or storage lots, but the sexual functions, both erectile and ejaculatory, are preserved. That's why the Optilium is FDA approved with promising results, especially for patients desiring symptom improvement and the preservation of sexual functions, but long-term data are required. So to sum up, the cavitating procedures remain the gold standard for treatment of PPH. They are associated with high rates of sexual dysfunction, and the novel minimally invasive procedures, the MIST, minimizes or apported at all the sexual side effects, but inferior in the urinary outcomes to the cavitating procedure. That's why patients should be properly counseled regarding the post-operative potential sexual dysfunction after the regular procedures, and the patients vary in their acceptance. But those who desire and willing to sacrifice the efficacy to somehow, in order to preserve the erectile and ejaculatory functions, are the best candidates for the MIST. Thank you.
Thank you very much, Professor Ahmed. Any questions?
Ahmed, thank you for this nice lecture. Artery embolization. Why didn't you mention?
I mentioned the process artery embolization as one of the procedures available.
Not
but
FDA approved.
I do believe.
Not FDA approved, yes.
Yes, not FDA approved, and I do believe, it's my concern that it is mainly commercial procedure.
Equalizer, equalizer, approved or not? Yes.
Yeah, and we do not perform the prostate artery embolization.
Equalizer, Ahmed, approved or not?
Yes, FDA approved.
Yes.
FDA approved.
Thank
with
you.
reported symptomatic improvement while preservation of the sexual functions.
Thanks.
Yes, thank you.
Any questions from the floor?
Thank you.
The next presentation is by Professor Egi Khan. I'm right in the pronunciation. Dr. Egi Khan. Premature ejaculation treatment beyond SSRI. Okay. So we conclude our session. Thank you very much.
Okay, thank you very much. Thank you.
As we move toward the conclusion of today's program, we are pleased to present our final session, Holistic Man's Health, Creating Excellence in Integrated Services, in collaboration with Arab Hair Restoration Association. Please let me welcome the chairpersons on stage. Professor Dr. دعاء جنينة, Professor Dr. عماد عبد الله, Professor Dr. كامل حميدة, Professor Dr. محمد الفحار, Professor Dr. مصطفى البرعي.
مساء الخير على حضراتكم، برحب بكم مرة تانية. الحقيقة حابب أشكر دكتور أسامة على الدعوة الكريمة وأهنيه على نجاح المؤتمر النسخة الرابعة، وكل سنة عن سنة. وشايفين دايما توبكس جديدة، واحنا بصفة عامة يعني سعداء ان يكون في مؤتمر يهتم بصحة الرجل. عنوان الجلسة النهاردة Holistic Men's Health Creating Excellence in Integrated Services in collaboration with Arab Hair Restoration Association. The first lecture will be gynecomastia, current concept and treatment modalities with Professor طارق رئيف, Asyut University. Please, Professor طارق. دكتور طارق رئيف موجود؟ تمام. هو جه؟ موجود؟ طيب استنى على موجود.
مساء الخير. Thank you for the kind invitation. I am Dr. طارق رائف, consultant and associate professor of plastic surgery, Asyut University. My talk today is about gynecomastia, current concepts and the modality of treatment. Restoration of the masculine shape of the chest wall is a rising desire of the male patients and a fundamental goal in treatment of gynecomastia. Body shaping for men is a demanding issue, including breast reduction procedures beside high-definition liposuction and facial surgery. The number of surgical treatment of gynecomastia and pseudogynecomastia has increased. Gynecomastia is the commonest clinical breast condition in males that makes them ask for medical advice. It may be unilateral or bilateral. It is usually associated with pain, anxiety, embarrassment, psychosocial discomfort, and fear of malignancy. A brief about male breast anatomy. The pectoralis major muscle is the main muscle of the chest, giving the chest its bulk and contour. The pectoralis minor, which is a thin, deeper muscle that stabilizes the shoulder. The subcutaneous fat, the thickness is variable according to weight and according to genetics. Glandular breast tissue and the skin envelope, which should be firm with good elasticity. Rib cage and the costal cartilage determine the base shape and chest projection. The ideal male chest should have a defined pectoral border, clear outline, especially the lateral and the inferior border. Flat to slightly convex lower chest with no glandular bulge, tight and firm skin with no laxity or ptosis, symmetrical and balanced chest. And the nipple areola complex should be positioned slightly lateral and inferior with a small diameter. Definitions of gynecomastia. Gynecomastia is a benign proliferation of glandular tissue in the male breast, while pseudogynecomastia or lipomastia is excessive development of the male breast from subareolar fat deposition without glandular proliferation. Gynecomastia is the most common breast problem in men. Most males experience some degree of gynecomastia during their lives. Overall incidence is 32 to 36 of adolescent boys. Up to 75% of cases are bilateral. The primary cause always is a relative or absolute excess of circulating estrogen with decreased circulating androgen or enhanced sensitivity of breast tissue to circulating levels of estrogen. There are many pathological causes of gynecomastia, mainly due to increased serum estrogen or decreased testosterone production. There is some cases of drug-induced gynecomastia, digoxin, cannabis, alcohol, cimetidine, spironolactone, calcium channel blockers. The histological classifications is 3 degrees. The florid stage with increased budding ducts and cellular stroma, the fibrous stage with extensive stromal fibrosis, and the intermediate stage with overlapping florid and fibrous patterns. Risk of malignant transformation, no increased cancer risk for patients with gynecomastia. Only if there is Klinefelter syndrome, the risk increase up to 60 folds. A brief about male breast cancer. It accounts for less than 1% of all breast cancer cases. Mean age detection is 65 years. 75% is ductal carcinoma, 20% is lobular carcinoma, and there is some risk factors for male breast cancer. There are many classification systems for gynecomastia, some older classifications as Webster classification, Rohrich classifications, and the most common classifications is Simon classifications. It classifies the gynecomastia into 4 grades. Grade 1 with minor enlargement as no skin excess. Grade 2A with moderate enlargement without skin redundancy. Grade 2B, moderate enlargement with minor skin redundancy. And the grade 3, marked enlargement with skin excess and ptosis. And we see these grades in post-bariatric patients. History is taken from all the patients, the age of onset, duration, symptoms, medications, and medical history. Breast examination is mandatory. Assessment of fat versus glandular predominance, laterality, symmetry, ptosis, skin excess, nipple position, and masses. And we have to differentiate between true gynecomastia from pseudogynecomastia and rule out breast cancer. Testicular examination should be done, and assessment for lack of male hair distribution and feminizing characteristics. Additional diagnostic tests could be required in certain cases. Management of gynecomastia depends mainly on the grade of gynecomastia and the cause of gynecomastia. In idiopathic cases, observation could be enough, as gynecomastia often regress after 3 to 18 months of enlargement. Gynecomastia present for more than 1 year rarely regress, and it needs surgery. Some drug treatments for gynecomastia is not effective, as tamoxifen, clomiphene citrate, and danazole. Pathological gynecomastia, we should treat the cause. And surgical management depend on the grade of gynecomastia. The principles of surgery is to remove glandular or fatty components to restore the masculine chest contour and to minimize the visible scars while achieving symmetry, and to tailor approach to tissue composition and skin excess. Marking and planning is mandatory to give the chest its ideal masculine contour. Modalities of surgical treatment: direct surgical excision in grade 1 gynecomastia if we have only hypertrophy of the gland. So a periareolar incision is done between 3 to 8 o'clock and subcutaneous tissue to expose the glandular tissue, which is excised with meticulous hemostasis and wound closure in layers. Some cases of only direct surgical excision. The second procedure is liposuction. Whatever the technique of liposuction, tumescent liposuction or power-assisted or ultrasonic laser liposuction or laser-assisted liposuction can aid in fibrous tissue breakdown. Choice of device based on surgeon experience and available equipment. Role of laser in gynecomastia surgery. Laser is one of the most useful technologies in modern gynecomastia correction. Its role is not simply fat melting, it contributes to precision, safety, and the contouring of the chest. Through selective fat emulsification, laser use an energy to emulsify adipose tissue while preserving vessels, nerves, and the connective tissues. Its benefits is easier aspiration with less trauma and bleeding, smooth chest contour. It improves the chest definition, and it facilitates the gland removal. It reduces the post-operative complication with less post-operative bruising and pain and faster recovery time. It allows a more predictable results. Some cases with only laser liposculpture. We can combine both liposuction and surgical excision in certain cases through a periareolar or subareolar incision for excision of firm retroareolar glandular tissue, and pull-through techniques through a small incision to remove the hypertrophied mammary glands. We do skin lifting in cases with skin ptosis or skin redundancy, especially in grade 3 gynecomastia, and the techniques could be circumareolar skin excision or Wise pattern or anchor pattern excision. This is a post-bariatric case with third degree or fourth degree skin ptosis. We remove the skin through a Wise pattern skin lifting. And in this case, we remove a skin through a circumareolar skin lifting. Intraoperative tips: mark standing, outline areas of fat versus glands, plan incision for minimal scarring, tumescent infiltration for analgesia and reduce the bleeding, intraoperative compression and careful hemostasis, consider drain selectively, conservative excision of glands to avoid contour deformities, and immediate assessment with patients upright to check symmetry. Complications of surgeries: hematoma, seroma, nipple area complex ischemia, could be avoided by avoiding aggressive undermining, over-resection or under-resection, and poor scarring. Contour irregularities, hypothesia or sensory changes, and recurrence. Post-operative care and follow-up: compression garments should be used for 3 to 6 weeks, depending on the amount of fat removed. Analgesia and the early ambulation, wound care instruction. Stage the follow-up at 1 week, 3 weeks, and 3 months. Discuss timeline for final contour. Thank you.
Thank you, Dr. Tariq, for the informative lecture. And now I will introduce Professor Ali Hassan Saber. والتوك بتاعته هتبقى very interesting about the high definition body contouring in males. اتفضل دكتور علي.
Mr. Chairman, good afternoon, everyone. Such a very long day and a very scientific day. Today my presentation would be about high-definition male body contouring, and my name is Ali Hassan Saber. I'm a consultant of plastic and reconstructive surgery in Alexandria University Hospital. Before I start, I'd like to thank Dr. Osama غطاس, CEO of الذكورة Centers, and the scientific committee for the DZAC conference. Such a very fruitful conference, and thank you for inviting me. I have no disclosures or any conflict of interest, and before I start, I have a question for the audience. What do you think is driving men actually to consider plastic surgery or body contouring? And I think this is because of social media and what's going around, especially in our mobile phones, regarding Facebook, Instagram, Snapchat, Twitter, and even YouTube. Actually, the result of what's going on is that teenagers and men and young adolescents themselves are under constant pressure. They want to look their best, always enhancing their appearance by removing the excess skin or removing the excess fat. And you can see our idol is Cristiano Ronaldo. Look at, he has almost 640 million followers. Look at how he looks. He looks very athletic with six packs, very a muscular look. We also have an Egyptian model, another one who is a very famous soccer player. This is how men actually want to look. And also they want to look the same with their colleagues and with their partners. They want to look sexy, they want to look healthy, they want to look very natural and fit. But actually, this is what happens on Instagram, and this is what we are facing with reality. And for men, actually, the top 4 procedures, or the very popular procedures for men to do in plastic surgery, number 1 is liposuction or body contouring. The second, as Dr. Tariq mentioned, is gynecomastia. And the third, as Dr. Marwan will mention, is hair transplant. And then comes rhinoplasty and ear surgery or otoplasty. But let's think how men can actually benefit from body contouring surgeries. They want very minimal scars, no adherent or visible scars. They want to feel confident, and they want to get the best out of body contouring or plastic surgery procedures by removing the surgical, by removing the unwanted skin or the fat deposits. But let's discuss what are the body shapes that we face as plastic surgeons, especially in the Middle East region. There are 3 different types of body shapes. Either the ectomorph, which actually the patient looks like a square, or the mesomorph is an inverted triangle or a triangle in general, or the very famous Egyptian body procedures, which is the endomorph, where they look actually like an oval shape. But the main area where fat deposits or the fat accumulates is around the abdomen, either extraperitoneal or subcutaneously, or through visceral fat. And this brings us to a very famous classification according to the WHO, which is the waist to hip ratio. According to men, it's the waist circumference divided by the hip circumference. It's actually 0.90 for men and is 0.85 for females. But let's look at the effect on the effect of fat on testosterone. If we have excess body fat, then definitely the testosterone level is less. If there is fat loss, then the testosterone level will increase. And I think this could be mentioned by the dear colleagues of andrology and urology. And then when we come to the diet, whether very low fat diet or healthy diet, I think Dr. DZAC can discuss this through the discussion. Let's look at the fat according to the effect on sexual activity. If we have excess body fat, then there is decreased libido. If there is very low body fat, then there is decreased desire. Then we want the healthy the healthy body fat or the healthy dietary fibers. I'll show a couple of cases where we did different body contouring procedures. This guy has lost so much weight through diet programs and using the machines that are very popular nowadays as the Vaser machine, which uses the ultrasound to rupture the adipocytes. We use the power-assisted machines also to get rid of the unwanted fat or the fibrous fat. But at the end, this is how we are doing our procedures. Through very minimal incisions, 3mm incisions. They become very invisible later on, 6 months after the procedure, and we get rid of the fat through these very tiny procedures. These are and let's look at the fat themselves, the fat that was aspirated. It can be ruptured using the ultrasound devices. This is the starter kit. I think that every plastic surgeon should use in body contouring procedure. It includes different devices. We are becoming very familiar with them nowadays, between the power-assisted machines, the Vaser machines, and high liposuction energy-based devices. And this is the cannulas. I think they simulate what we do in laparoscopic or endoscopic surgery, so we are becoming very minimal or minimally invasive procedures. And this is the patient on table. You can see he has a very good athletic look. We managed to achieve the V-tapered look. He has got rid of all the fat that we wanted, and actually we can still use the fat that was aspirated later on to achieve a very muscular look, especially in complicated cases where there was over-excision of the glands in gynecomastia cases. We can re-inject the fat again in the pectoralis major muscles, and we can have this very strong athletic look later on. I'll show a couple of cases also regarding the different body contouring procedures, high definition body contouring procedures that we did. Not only in males, but it's more popular in females, where we want to get rid of the fat from different parts of the body and do some more of liposhifting or injecting the fat in different areas and achieving a very good look. The second part of my presentation will be actually something very famous. With the ongoing body contouring procedures after bariatric surgery. You know, in the past 10 years, bariatric surgery was very popular in Egypt, and we have a series of surgeons who have done so many cases of sleeve surgeries or bypass surgeries, but later on, this is what we get in our clinics. We get skin redundancies all over their body. They have no fat. They already burned all the fat that's present in their body, but they have so much excess skin all over the body. And this can never be treated only with machines. We have to use our scalpel, and we have to use our different incisions to get rid of the excess skin and look at how big the skin that was excised from this patient. This was a circumferential belt lipectomy, or removing the skin all over the lower abdomen or the lower trunk. And different cases, these scars are usually become hidden or invisible between 6 months to 1 year later on, but at the end, I can show you, this is actually 1 month. He has a very little bit dark scar, but later on this scar fades away. And this is the amount of resected skin, usually from the thighs, from the abdomen, and even from the breasts. And then this is how patients want to look like at the end. They can wear their clothes easily without having any bulges all around. They can have different sizes, get their sizes a little bit smaller than usually before. And this is the amount of excised skin. This is a totally different procedure than just doing the high definition liposuction. It's more of excising the skin circumferentially. But before I finish my presentation, never operate on patients who did sleeve surgeries or morbid obesity surgeries before 18 months, and their their BMI has to be less than 30 kg. And another thing is that if their BMI is more than 35, never to operate on them, because you will have higher risk of complications later on. And before I finish, I just want to invite you all to our next ISEPS meeting. It's an Egyptian Breast and Body Forum. This is our 2nd edition. It's going to be in June in the North Coast. We will definitely have a session about men's health and andrology and penile implant usage. Once again, thank you again for this lovely opportunity. Thank you, Dr. Osama. And if I'm available for any questions, this is my contacts. Thank you so much.
Thank you so much, Dr. Ali Hussein Saber, for the presentation and enhancing body physiques. Our last talk will be about hormones and hair, clinical insights into androgenic alopecia in men by Dr. Marwan Adel from New Giza University.
Good evening, everyone. After a very long day, thank you all for being still here. And I'd like to thank the organizing and the scientific committee for their kind invitation. I'm Marwan Nuruddin. I'm a plastic and a hair transplant consultant. I'm diplomat of the American Board of Hair Restoration, and I'm Secretary General of the Arab Association of Hair Transplantation. So my talk is about hormones and hair. So why the same hormone that creates masculinity can silently reshape the scalp? Androgen at puberty will stimulate the androgen-sensitive hair, beard, chest, body hair, and then the man will look masculine. But others, the same hormone, will act on the scalp hair and starts falling out. The other thing, two brothers having the same genes, one starting to lose his hair at 30 years old, the other one at 60, still having his hair but becoming thinned out. So why does this matter? Because baldness affects usually more than 80% of men when they reach the age of 70. It affects their self-image and aging perception and the mental health. One of the most common reasons why men seek dermatology, aesthetics, and hair restoration. Like Dr. Ali said, hair transplant is now considered the third aesthetic procedure done by men. And the main problem, it is progressive. It doesn't stop. Once it's there, it always progresses, and according to the genes, whatever the grade the patient is. So the main problem, it's not the skin, it's the hair follicle itself. We have a problem with the hair follicle. It's a mini endocrine organ. It's not a passive organ. The hair is not just the hair. And this is where the problem occurs. Here occurs hormone conversion and receptor modulation. And the misunderstood villain, the testosterone, is it the reason why the hair is lost? Testosterone levels in bald men are usually normal, and in castrated men, they do not develop AGA, and there were studies done before about this. And this misunderstood villain will be converted into DHT, and this is the true villain. The DHT hormone is the main problem. So the DHT, dihydrotestosterone, is 3 to 5 more times potent than the testosterone, and it acts primarily on the genetically susceptible follicles. So it is not just about the hormones, it's about the genetics as well. So not every follicle will be affected by the problem. There must be an androgen receptor working on the dermal papilla cells where the DHT hormone will act on this follicle and the follicle will fall off. And as well, usually AGA patients have higher local 5-alpha reductase enzyme activity. So what happens when the DHT attaches to the androgen receptor? The hair starts dying out. You never lose the hair all of a sudden. It just starts to become shorter, become thinner, more anagen to telogen ratio becomes less, and the hair starts to shrink, and then fibrosis occurs and the hair doesn't grow back out. And is only the testosterone is the only effector on the hair follicles? Absolutely not. We have a lot of hormones. Cortisol, estrogen, growth hormones, thyroid, prolactins, everything can affect the hair, but we are talking about AGA. So early diagnosis is a must. We have to treat or diagnose AGA early because this is where the follicles will be salvageable. We can treat this, we can stop the progression. But if we come late, it's like watering a plant without leaves. So what we have is medical therapies. Finasteride reduces the DHT hormone, dutasteride. Finasteride is one of the 2 only FDA-approved drugs to treat AGA. So dutasteride is still not FDA-approved. It, yes, reduces the DHT more, but it has a longer period of complications that might occur. Minoxidil, main effect is vasodilation to increase the nutrition and to save the hair. And we have the low-level laser therapy, which induces as well, improves the anagen phase and, prolongs the anagen phase, and it increases the blood supply to the follicles. But what's new? These things are the old things that has been there for years. We didn't have a breakthrough still yet in the treatment of hair. But what is new is the regenerative therapy. This is what is now the main star of treatment of androgenic alopecia. Stem cells, since it has been there, always been studied. The main source now we take the stem cells from are the fat. We either inject nanofat or we enzymatically digest the fat and we inject the SVF. It will not still produce new hair. What's lost has been lost, unfortunately, but it saves the falling hairs. Hair stem cells, nowadays we have lots of devices that you take the hair follicles and you extract the stem cells from the hair itself and you start injecting it as well, not to produce new hair, but to save the hair. Exosomes, we have a lot over the market nowadays. We have plant-based, we have human-based, we have others that are synthetically produced, but everyone is a little bit afraid of the exosomes. No one knows the stop point of the exosomes. It's still not FDA approved. So we started to have the autologous exosomes. There are now devices that try to extract the exosomes from the platelets and others that start to extract it from the fat, but it is one of the newer things that, again, we are trying to stimulate the hair. PRVP, this is the PRP, or this is the new name of the PRP, in which lately we discovered that the PRP is full of exosomes, so that's why they're calling it platelet-rich vesicle plasma. Newer medical treatments, oral minoxidil is getting back on the market again. Still not FDA approved because we don't have the correct dosage. We have the dosage starting from 0.25 milligrams up to 5 milligrams. Nowadays, most men take 2.5 milligrams, women take 1 milligram per day, but still needs more studies to have to become FDA approved. Mimatoprost has been there a long time ago, applied locally. It prolongs the anagen phase and improves, has been used for the eyelashes, eyebrows. Nowadays, starting being used as topical treatment for the androgenic alopecia. And the latest is the PP405. It is a drug that's still under trials. Lots of promises about it, but nothing is scientifically still. It's under the 2A now trials. And it's applied locally. Once it's there, it will be a breakthrough because it is considered that it reactivates the dormant follicles that has been dead. Still, if there's fibrosis, definitely it will not reactivate it, but if it is the stem cells are still there, the dermal papilla cells, it's a drug that will provide. Hair cloning, anyone heard about hair cloning before? Okay, this will be a breakthrough if we have been able to do a hair clone. Every time a patient asks about this, I tell them if we are able to clone a hair, we have a lot of different things that's more important than the hair that will be cloned first. So it's way too far, a little bit, to be able to clone the thousands of cells to be put in a single structure as it is. The only thing that's been there being cloned is the dermal papilla cells of the hair cells. So what's being done nowadays in the UK, they are very famous for this. They take the hair, put it in a hair bank, as like the blood bank. So while you're young, still having young hair, putting it into the bank. So when 20 years, maybe the hair cloning is there, you are going to clone young hairs, not old hairs. But the only thing that being cloned nowadays is the dermal papilla cells to be injected next to the hair, so to stimulate the hairs instead of doing multiple PRPs or exosomes or stem cells, then just doing a one session of dermal papilla cells. So, beyond the medical therapy, after doing medical therapy with patients who lost their hair, there's no treatment that can provide you with the hair again, so we have the hair transplant. I don't like to call it the old method, but it is the strip surgery, what's called the follicular unit transplantation, the FUT. It has its advantages, very nice in women if it's being correctly done. The newer, the follicular unit excision, which is the FUE, and it's a very important thing that the patients understand that when we do a hair transplant, we do not stop the medical therapy. We have to continue on the medical therapy to save what's still there of the original hair. So what's being new with the surgery? So not much actually, but what we have been doing or providing more is the long hair FUE, in which you extract the hairs. As you can see in this patient, he's having a scar over her face, and we took the hair from his back of the head without needing to shave, and this is due to the developments being done to the machines. Body hair extractions are now gaining more and more popularity. We can take the hair, some people who are high grades of baldness, who doesn't have any hair on the top of their head, the donor site is not that much, so we can take the beard, we can take the chest, the abdomen, and even the pubic hair. Implanters, these pens that we use to implant the hairs, these are lovely things, instruments that save the hair and provide a better results. Robotic FUE, actually it is not new. Anyway, it has been there since 2011, and the only company that does the robot is called the Artis. With the development that has been done over the last 5-6 years with the machines, lots of doctors have been stopped using the Artis nowadays, but it's one of the things that's there. And lastly, the SMP, which is something looks like a tattoo that can be used to camouflage the scars. Someone having an AGA still early, that can be done. It's a medical tattoo, let's call it like this, but it's the scalp micropigmentation. And following these results, and following these things, these are the things that we can do with a hair transplant, giving a very natural, nice results. And even eyebrows, this with the microblading era that has been there like 7-8 years ago. These are things we've been doing now a lot. And even with scars, we can do a hair transplant. This is a single session of a hair transplant. There's no need to do an expander. So with these new modalities and everything, with the fat, with the stem cells, with the exosomes, we can reach lovely results like this. So remember the two brothers? They're having the same genes. One did a hair transplant and the other one had to take the only medications. So lastly, early diagnosis is a must, so as to save the hairs before it enters the period of being non-salvageable. The proper patient education. Unfortunately, loads and loads of social media marketing ploys whenever you start just giving names, and DHI, not micro FUE, nano FUE is a fire, QHT nowadays is a name. So these are totally make the patients become confused, and they do not understand what's being done and what's true and what's just a hoax. And long-term planning. Always this is the most important thing. I cannot look under my feet right now and see the patient. I have to imagine how the patient will look in 10 years. So if I did a very huge hair transplant nowadays and the patient's having a frontal hairline, very nice frontal hairline, and in 10 years he loses all the hair, he will look funny. So we have to always think with the patient when to do the vertex, when to do the hairline, when to put it lower, when to put it higher, and this is the most important thing. I'd like to thank you all. Thank you.
So let me thank Dr. Marwan for a fruitful and illustrative presentation, and you give all the males with hair problems actually hope. So if you have any questions, so anyone of the floor have any questions?
هي أنا حابب أسأل دكتور علي. دكتور علي محاضرة شيقة جدا وتوبيك جديد علينا. احنا متعودين يعني دايما في مجال السمنه البودي كونتورينج ستات يعني انت وريتنا انه ممكن يكون مفيد جدا للميلز بالذات افتر البارياتريك سيرجري. فسؤالي لحضرتك ايه الكومن كومبليكيشنز اللي ممكن تحصل من البروسيجرز اللي حضرتك قلتها لنا والفريكونسي بتاعتها قد ايه؟ يعني less than 1% ولا 5%؟ لان في ناس كتير عندها تخوفات ساعات فات امبوليزم حاجات بالشكل ده، فهل الكلام ده وارد؟ وحضرتك لو بس تإلابوريت شويه على حته السايد افكت.
دكتور كامل مفيش طبعا surgical procedure without complications، بس it's based mainly on the correct choice of the patient. This is number one. الcomplications usually متقسمه لجزئين، either يا physician related يا patient related. واكشلي ان هي البرسنتج بتوين بوث از ايكوال. بس mainly الستاديز بتقول ان الفيزيشن هو اللي بيعمل الكومبليكيشن ذات نفسه. ونمبر 1 complication is the bad choice of the patient. مثال ان السموكرز مثلا are not favorable ان احنا operate upon them unless they quit smoking at least between 21 days up to 1 month. الcorrect choice of patient برضه based على الcorrect base البي ام اي ان هو ما يبقاش زي ما انا شرحت above 35. يعني ما ينفعش ان انا اعمل الفيري morbidly obese patients ان انا اعمل لهم body contouring procedures. لازم الاول يمشوا على دايت بروجرام او ان هم ينزلوا يعني يبقى في modality of weight loss علشان خاطر ان احنا نبدا نoperate upon them. وان احنا نعمل اكتر مثلا يعني في ناس بتعمل 7 procedures في single stage. الستيجنج بتاع البروسيجرز ديت تبقى افضل مليون مره although الانفلونس بتاع البيشنتس ان هم عايزين يخلصوا كله في سنجل وان سيتنج. فان احنا نقسم البروسيجرز ديت على 2 ستيجز بيبقى افضل طبعا، بيقلل الموربيديتي بنسبه كبيره. والاهم من كل ده برضو ان احنا يبقى في كوركت يعني زي ما بنقول بري اوبراتيف بيشنت كونسلنج واسسمنت اللي هو بيبقى اللاب تيستس بتاعته. لو مثلا الموضه الايام ديت حضرتك ممكن تقول لي برضو الجي ال بي 1 ريسبتور، في ناس بتقول ان هو لازم يقف قبلها ب 15 يوم، في ناس بتقول ان هو ما يقفش. فدي برضو يعني واحده من الحاجات اللي احنا لازم نبقى يعني تكونسيدر ان البروبر بري اوبراتيف اسسمنت هو ده اللي بنسبه كبيره بيقلل البوست اوبراتيف كومبليكيشنز.
هو فعلا الجي ال بي 1 بصفه عامه المفروض بيفور اني اوبراتيف بروسيجر توقف قبلها باسبوع او 2، لان هي بتديلي الجاستريك امبتنج فبتزود ريسك اوف اسبريشن اثناء التخدير، لان طبعا معظم الحاجات دي بتعوز جنرال انستيزيا، فهتبقى مور سيف للبيشنت انه يوقفها وما جاتش طبعا على الاسبوع ولا 2 في الجنرال ريزلتس بتاعتها، لان العيان بيكون بياخدها بقاله شهور يعني.
انا لو وريت لحضرتك انا عندي يعني ما فيش جراح ما عندوش كومبليكيشنز طبعا، بس هي الكومبليكيشنز تبقى يعني ديزاسترس شويه يعني.
انت لحقت قبل ما اقول لك على الكومبليكيشنز
يعني بس انا مش هوريها للاودينس ممكن اوريها يعني، لكن هي مش بتبقاش الطف يعني. ما حدش فينا بيبقى عايز ان هو ياخد الباث واي ده او السكه ديت، بس يعني ان احنا بروبرلي تشوز البيشنت كوركتلي ونشوز البروسيجر ذات فيتس ذس بيشنت.
طيب دكتور علي، عايز اسالك سؤال عشان البودي ايمج ده ايشو لوحده، وان احنا كلنا بنشوف حاجات حلوه قوي وكلنا looking to reach this picture this model. is this true؟ يعني في مش virtually في الريل لايف حضرتك لما بتشتغل على حاله هل بتوصل لل 100% من اللي هو في دماغها، ولا still after all this عمرها ما بتطلع بالشكل اللي احنا بنشوفه في الفلترز
بص حضرتك خلينا متفقين ان البودي كونتورنج بروسيجرز بصفه عامه هي اتس ا لايف ترانسفورميشن. هي بتحط المريض على اول التراك، بس يعني ان احنا نخلصه من الانوانتد فات ديبوزيتس او اللوكالايزد فات ديبوزيتس او الاكسس سكين اللي موجود عنده، وهو هي كان نوت جيت ريد اوف بقى سواء بالدايت او بالماشينريز او باي حاجه نون سيرجيكال. فاحنا مجرد ان احنا بنحطه على بدايه الطريق او اول التراك دوت، بس هو في جزء ان البيشنت هاز تو كونتينيو. يعني ما ينفعش ان احنا نعمل بروسيجرز ديت ويرجع هو للايتنج هابتس بتاعته اللي كانت موجوده قبل كده. ما ينفعش مثلا ان احنا نعمل البروسيجرز ديت ومثلا يبقى هو عايش سيدنتري لايف. هي مجرد ان احنا بنحط المريض على اول التراك ان هو ياخد هيلثي لايف ستايل، او ان هو his life changes، يبقى فيه زي لايف ستايل موديفيكيشن اكتر.
يعني بيحصل فعلا ريباوند لما الناس بيبقى أسوأ من الشكل الطبيعي قبل البروسيجر.
يمكن مع اللي بيحصل الايام ديت ان الريباوند دوت البرسنتج بتاع الريباوند اقل بكتير من زمان، وبسبب برضو ان البروسيجرز ديت على قد ما هي بتبان في الاخر بيفور وافتر في 15 سكند شوت، لكن الجيرني او الهاسل اللي بيحصل في النص او يعني المتاعب اللي المريض بيمر بيها في النص بتخليهم برضو اوير ان هم يعني يمشوا على الرايت باث. يعني
ايه الاماكن اللي حضرتك ما تنصحش ان هي تتعمل؟ يعني احنا طول عمرنا نعرف الارم مثلا لما بيتعمل في سكار كده بيبقى شكله مش لطيف وعمره ما بيهيل، از ات ترو؟ يعني في اماكن يفضل ما تتعملش؟
هي ما فيش حاجه اسمها ما فيش اماكن ما تتعملش، هو كل حاجه ليها يعني ليها سيرجيكال موداليتي، بس زي ما انا شرحت ان هو العيانين they want to become minimally invasive no scars او minimal scars. الفكره بتاعت السكارز اللي بتبقى موجوده في البودي ايمج ديت او في البودي بصفه عامه، هي ساعات بتدخل العيانين في زي مش سايكيك باث، بس ما بيبقوش راضيين شويه عن الاند ريزلت. فعلشان كده احنا بنحاول ان احنا نبقى مينيمالي انفيزيف او نون انفيزيف على قد ما نقدر يعني. لكن ما فيش يعني احنا بنعمل الثاي ليفتس، بنعمل الارم ليفتس، البريست، الابدومين، دلوقتي الفيس ليفتس ديت برضه فيها سكارنج وفيها نيرف انجرز وي. لكن هو يعني اغلبيه البودي بارتس او كلها بتتعمل يعني.
سؤال اخير بقى على حد علمي في الراينوبلاستي، ان عن طريق يعني كمبيوتر بروجرامز واي اي ممكن توري شكل المريض وهو قاعد قدامك، توري له بيفور اند افتر، يعني ايه اللي هيتوقعه من السيرجري. فهل برضو عند حضراتكم ده موجود، ان هو توري المريض انت دلوقتي شكلك كده وات تو اكسبكت، يعني ده موجود؟
يعني برضو دكتور محمد الفحار هو برضو ممكن يجاوب حضرتك في الحته ديت، لكن انا هشرح لك ان احنا بقى عندنا انترفيسز او يعني موديولز معينه، مش هي مجرد بتدي 80 to 90% تصور للمريض هيبقى شكله عامل ازاي، لكن هي مش 100% accurate. فهي مجرد ان هي it's a factor influencing patients ان هم يبقوا operated يعني، او ان هم you go through the surgery. لكن هي موجوده بقى في الفيس، في البريست، في البودي، يعني موجوده في اكتر من مود عامه، وموجوده من اكتر من سوفت وير. يعني في سوفت ويرز اللي هي مجرد حضرتك بتصور ليها كاميرا معينه 360 بتصور العيان، كاميرا كبيره للايفون والايباد، لمجرد بس ان حضرتك كمان ممكن تابلود فوتوز قديمه ونوري العيان بيها شكله هيبقى عامل ازاي.
شكرا علي. يبقى يعني هتكلم بس على نقطه السيميوليشن، والسيميوليشن جزء يعني عاد مهم، لان العيان محتاج ان هو بيسال الدكتور انا عاوز اشوف شكلي، وده طبيعي حقه. القصه كلها تكمن ان انا whatever simulation I did، يعني في ناس بتعمل سكتش على ده، في ناس بتعمل بسوفت ويرز بعضها مجاني بعضها له سبسكريبشن. القصه بتكمن ان انا بقول للمريض ده شكل قريب من الشكل اللي احنا هنوصل له في العمليه. في بعض الدول بيخلوا المريض يمضي على consent ان this is a simulated version، لان الناس اللي ما بتتكلمش عن النقطه الثانيه ان هو he can sue the surgeon. he can sue the surgeon، بيقول له انت قلت لي الصوره دي you send it to me by WhatsApp على السوفت وير وانا I didn't look like it. ففي consent بيتمضى على السوفت ويرز ديت ان دي generated pictures او AI tools، لان انا اقدر اعملها دلوقتي باي اي، واقول له ده بيساعد الجراح اللي بيشتغل بادي كونتورنج او راينوبلاستي دايما حاطط صور العيان قدامه على الترابيزه، على المونيتورز، على السكرين، على اللابتوب، عشان يشوف شكله، بيتبص على شكله حقيقي. الصور اللي احنا بنشوفها دي صور مفروض بتتشاف بعد 6 شهور وسنه. مفيش حاجه ان انا اوري صوره immediate، مش ده الحقيقه. فالقصه ان السيميوليشن مهمه، بس لازم الدكتور في الكونسلتيشن بتاعه يكون حريص، ما يوعدش المريض ان هو ده 100% what it looks like، لان هو ممكن يفاجئ بحاجات جوه العمليه، وممكن شكل الاستراكشرز نفسها تتغير. يعني الوند هيلينجز بروبلمز دي مش محسوبه. نفترض ان عيان اتعمل له راينوبلاستي وللاسف السكارز بتاعه عاده ما بيحصلش فيه كولايد، بس طلع له كولايد. يقول له مثلا اشمعنى دي دكتور لما قاعد ابص كده طول النهار قاعد يبص لمناخيره فوق، ان هو جرح ما بيبانش اثر، تمام. بس انا لو وريت له صوره وشلتها بالفوتوشوب وقلت له ده كونسيلد سكار، واقنعته ان دي عمليه من غير سكارز. في ناس بتعمل سيلينج للفلتر للسكارز عشان تقول انا بعمل جرح شكله كويس، وهي اكشولي فوتوشوبت. فالعيان هيبص لا مش دي الصوره. فالقصه دي سيميوليشن مهمه، بس لازم تتاخد بحذر يعني.
قبل ما ادي حضرتك انا بس عشان النقابه والمسؤوليه الطبيه والكونسنت فورم، فانا يعني بانسس يعني برجع اقول لحضراتكم كلكم يعني حمايه لكم الكونسنت فورم في اي حاجه لازم العيان يمضي ان هو موافق على البروسيجر ومتوقع ان ممكن يحصل مشاكل، ان شاء الله ما تحصلش، بس ده امان لحضراتكم، لان ده قانون المسؤوليه الطبيه الجديد وبعد التعديلات اللي اتعملت فيه هي فيها جزء كبير لصالح الاطباء. هو طبعا ما لا يدرك كله لا يترك كله، لكن بنسبه كبيره جدا هي احسن من الاول. مفيش حبس الاطباء، الغرامات نزلت من 10,000 ل 100,000 ماكسيمم. بس اهم حاجه فيها الكونسنت فورم، لان ده من اول ستيب هيحمي الطبيب حمايه كبيره ويدفع عنه كتير من الاذى يعني اللي بيحصل، واستغلال العيانين طبعا اللي هم بيستنوا على البرفكشن، او الدكاتره اللي بيعملوا زي ما حضرتك بتقول يبين لهم الدنيا ورديه وما تطلعش النتيجه، هيمسكوا في اصغر نقطه يعني. فدي نقطه مهمه جدا. اتفضل.
هو قبل ما اسال دكتور علي، هو طبعا الانفورمد كونسنت هو كمان يعني انا لازم بشرح للعيان ويبقى عارف الديتيل. ساعات لما بشرح له هو بينيجوشيت مي تاني، بيرجع تاني يقول لي يمكن احنا زودنا في الداتا ريجستري، عندنا فويس نوتس على الداتا ريجستري، وبنبقى معرفين العيان قبل ما نبدا الفويس نوت ان احنا مع العيانين التريكي، عيانين الريفيجنز، عيانين اللي هم عارفين ان هم شويه عاملين لهم ليبلز وفلاجز عندنا ان هم عيانين شويه انوينج يعني. فبنقول لهم احنا هنبدا معاكم بعد الانفورمد كونسنت ان في فويس نوت، واحنا هنعمل 1 2 3، فهل انت موافق على ده؟ فهو موافق او مش موافق. لان ساعات حتى بعد الريتن انفورمد كونسنت والله انا ما خدتش بالي قوي. فيعني دي نقطة مهمة. أنا بس حبيت دكتور علي أشكرك على يعني أمانتك، وأنت قلت حاجة إحنا كبرياتريك سيرجن لما أنت قلت إن العيان بوست برياتريك حطيت 2 كرايتيريا مش واحدة بس، يعني مش بس الوقت، مش بس سنة ونص بعد البرياتريك سيرجري، لا ده أنت حطيت ليميت للبي ام اي كمان. فأنا بصراحة حبيت أشكرك يعني جدا، وخصوصا مع البريشر بتاع العيانين. يعني كتير حتى بيقول لنا احنا هو من بدري عاوز يعمل يعني لايبوسكشن، عاوز يعمل ريشيبنج، فانت حطيت له 2 كرايتيريا. وكمان انا عجبني ان انت قلت ان ده از ريجيد رول، يعني ان انت ما بتنزلش عنه، ان ده هي شود يكون عدى الفتره دي. فحبيت اشكرك قوي على دون. وحبيت اسالك العيانين السوبر اوبيز بوست بارياتريك اللي اوزانهم عاليه جدا، اللي هم ساعات يجي لي عيانين 240 و250 كيلو، خس 120 و130 و150 كيلو، دول نتائجهم ايه؟ ويعني بتتعامل معاهم ازاي، خصوصا مع السايز والارمز يعني؟
دول اللي هم اللي بيخشوا تحت المالتيبل او 2 ستيجز او 3 ستيجز، ودول في الاغلب بيبقوا نزولهم في الوزن، يعني حضرتك ممكن تقول لنا الحته ديت، ان نزولهم في الوزن بيبقى من 100 to 120 كيلوز يعني ماكسيمم مثلا، لكن بيبقى عباره عن سيريز اوف اكسيجنز، يعني سكين اكسيجنز وسكين ريسكشن واكسيجنز مينلي، اكتر منها ان هي بتبقى هاي ديفينيشن بودي كونتورنج. وفي الاغلب العيانين دول يعني الكومبليكيشن ريت فيهم بيبقى اعلى شويه يعني.
بالظبط، عاوز اسالك على كده. هم حتى طموحهم اكيد بيبقى عالي، بس هل انت بتحط لهم ليميتيشنز ان هو ما يخلي الاكسبكتيشنز بتاعتك مش عاليه قوي، ولا هم بيجيبوا نتائج كويسه خصوصا في السايز والارمز يعني؟
بص حضرتك على اللونج ران يعني من البيشنتس اللي عاملين موربيد اوبيستي سيرجرز بصفه عامه، ويمكن دي ستادي انا يعني شاركت فيها مع حد من المتخصصين في البرياتريك سيرجري، ان هم عندهم سيريز من المال ابزوربشن، وعندهم سيريز من الفيتامين ديفيشنسيز، واغلبيتهم عندهم انيميا، والبلاد جلوكوز ليفل بتاعهم مش مظبوط وده راجع ان هم البوست اوبراتيف بقى، بوست برياتريك بقى الفولو اب بتاعهم، هم العيانين بيرفيوز ان هم يمشوا على الفيتامينز ويمشوا على المينرالز ويمشوا على هيلثي لايف ستايل معين، وفي منهم بيبقوا سموكرز كمان. فالستيجنج يعني او الستيجنج بتاع البروسيجرز هنا بيبقى افضل طبعا، ده نمره واحد، ان احنا يعني مش هعمل فيها هيركليز واخش اعمل المالتيبل بروسيجرز في سنجل سيشن، بس احنا بنقسمها. يعني مثلا لو في فيميل ممكن نعمل البريست مثلا والابدومين، البريست والارمز مع بعض، ممكن نعمل الابدومين والثايز مع، يعني تقسيم البروسيجرز مش حاجه سيئه، بس المهم ان العيانين يتقبلوا الفكره ديت ان احنا نقسم البروسيجرز يعني.
بشكرك جدا، وانت يعني اديتنا خيط ل lot of questions يعني، وشكرا جزيلا.
انا اشكر علي، لان القصه ان احنا ما نخليش المريض دايما to push the surgeons ان هو يعمل له كل حاجه مره واحده. يعني لو المريض جه وقال لي في دكتور بيعمل يعني توتال بادي كونتورنج في وان سيشن، انا عن نفسي هخاف، لان العمليات دي لانثي، فيها بلاد لوس جامد، يعني لو مش متحضر كويس يعني it's recommended ان انا I shouldn't exceed 2 procedures فقط، unless ان انا العيان جسمه صغير صحته كويسه، تتعمل بحذر شديد. هي دي النقطه المهمه يعني، فما استعجلش ان انا اشرح للعيان ان انا ممكن اعمله 2 stages 3 stages كل ما بين مره ومره 6 شهور او سنه، يعني واي نوت، مش مفيش داعي. حالات قليله ممكن، بس لازم اكون فيري كوشس فيها جدا.
اعتقد كانت جلسه غنيه وشيقه وديسكشنز ثريه. شكرا لكل السبيكرز، شكرا لكل زملاء التشير بيرسون. دي اخر سيشن. بنشكركم على الصمود وان انتوا قعدتوا معانا اليوم كله، وان شاء الله نقابلكم كل سنه على خير في DZAC 5.
Thank you all for this great discussion. Ancient Egypt contributed enduring symbols of knowledge, renewal, and civilization to human history. We now invite you to watch a short film highlighting the pharaohs whose leadership embodied wisdom, authority, scientific advancement, and the foundations of healing and medicine.
Thousands of years ago, there was a pharaoh sitting on Egypt's throne, searching for a cure, unlocking the mysteries of manhood. Centuries later, in the halls of the Ptolemies, a physician wrote with reason and science. His name may be lost, but his dream lived on. In the age of the Mamluks, he returned in a turban, studying the human body, not just to heal, but to truly understand it. In the 1940s, with the grace of the Pashas and the heart of a healer, a doctor wrote, "We haven't found the perfect cure yet, but we're getting close." And now, at Dar el-Zakora, that dream is alive. With cutting-edge technology and sharp diagnostics, we decode each man's unique biology to treat and restore balance and confidence. As for tomorrow, we already see it. AI will craft your treatment plan before you even need to ask. Dar el-Zakora, from history into the future, from the legacy of our ancestors to the steps they'll take tomorrow.
And now, let's move to another short film.
Once upon a time, long, long ago, there was a time when men, true men, were pashas. Not merely pashas by their suits and tarbushes, but pashas by their stance, by their word, by the very look in their eyes, pause that made anyone recognize their true worth. You see, they didn't just get the title of pasha for nothing. They were gentlemen inside their homes, caring for them as they did their own name. Gentlemen with their friends, a support in tough times and company in joyful times. Gentlemen in their work. Their word was a contract and their promise unwavering. We have not forgotten this era. We in Dar al-Zakora, we brought it back. Here, our focus is on men's health so they can always remain true gentlemen in every aspect, in their physical well-being, in their appearance, and in their strong presence. From one generation to the next, the distinguished gentlemen are returning. And now, right here in the heart of Mohandesin.
And now we'll watch another video for today's conference.
Distinguished
I wish you all successful in the Beijing conference. Thank you. Welcome.
And finally, as we come to the conclusion of the DZAC Annual Conference on Andrology and Men's Health, I would like to extend my sincere gratitude to everyone who contributed to the success of this event.
Our deepest thanks go to our speakers and session chairs for sharing their expertise, to the scientific committee for ensuring the high quality of the scientific program, and to our chairpersons whose vision and leadership made this event possible.
We also thank our organizers and all attendees for your active participation and valuable discussions, which have truly enriched this conference. We hope that the knowledge exchange and the collaborations formed over this day will continue to advance the field of andrology and improve men's health.
On behalf of DZAC Group, we're honored to officially declare the closing of day one of this conference. Thank you for joining us. We hope you found the sessions enriching, the discussions thought-provoking, and the exchange of ideas meaningful. And we look forward to welcoming you again next year.
استاذن بس من كل الحضور نيجي عشان ناخد صوره كلنا مع بعض.